This sitting is resumed. Prior to the suspension, we were in Standing Finance Committee. We return to the Standing Finance Committee.
This House is in Standing Finance Committee. When the House was suspended, we were on Head 86, Ministry of Health and Wellness. To this we shall revert. Honourable Member for St. Michael, South Central.
Thank you very much, Mr. Chairman. I have 3 questions in my first round of questioning. These are very simple and straightforward. Some of them were touched on by the ministers and their teams earlier, except I'm asking for a little bit more specificity. Let me start with 2 issues that are critical for the government of Barbados, or that have been, especially with respect to the Barbados Economic Recovery and Transformation Plan. Under the BERT program, under the BERT plan, the government and its statutory, state-owned enterprises, statutory institutions are not to accumulate arrears. Now, the accumulation of arrears is an issue of financial governance, is one of the reasons that we had these arrears targets under the BERT plan. But it's also an issue of small business growth and development, because we know well that a business that has outstanding receivables is also not able to reinvest those resources in growing and in its general day-to-day operations. So I ask this question from the perspective of not just meeting our requirements under the BERT plan, but also making sure that we are true to our word when we talk about supporting small business. And it is this. There are many people who have reached out, not just in my capacity as a member of parliament, but also in terms of what they see as my association or former association with the Ministry of Finance and with Economic Matters. And their concern has been the issue of their own receivables from the Queen Elizabeth Hospital. So these are providers to the Queen Elizabeth Hospital, supplying essential goods and services, who themselves have issues with their own cash flow and with their own reinvestment in their companies because they have outstanding receivables from the Queen Elizabeth Hospital. And before the minister comes back in to repeat the issue of scarce resources, I want to emphasize that this is not a question of the quantum of resources. This is a question of the financial and economic governance of the QEH, and making sure that the cash flow matches and the financial management matches your commitments. So I would like to hear a bit about what are the challenges there. I would like to hear a bit about how that is going to be resolved in this financial year. I hear us talking about things that we are looking at and things that we are considering, but I want to remind us all in this honourable chamber, if I can, through you, Chair, that we are looking at the estimates of revenue and expenditure for the year 2022 to 2023. We are discussing what we are executing in this financial year. And so related to that, not just the issue of receivables from the QEH that are outstanding as a perpetual issue, but I would also want to hear quickly, what is the CapEx? What part of that 125 million that is allocated under subprogram 375 for the QEH, what part of that is CapEx in this financial year, and what is it going to be spent on? Thanks.
Thank you, Honourable Member. and I do agree with you, the BERT program stipulates that we must not carry any payables beyond the agreed time frame. In respect of the Queen Elizabeth Hospital, the Queen Elizabeth Hospital receives a transfer from the central government, as I indicated, in the next financial year, of approximately 125 million, up 5 million from the 120 in this financial year. The second issue is that the Queen Elizabeth Hospital benefits from the health service levy. I think when we look at the projections, it would have been upwards of about $55 million that we're projecting to gain in this financial year. Obviously, with increased economic activity in the forthcoming financial year, we presume that we can get back to maybe above the 55, maybe hopefully $60 million, obviously depending on the level of activity out there. Other revenue from the Queen Elizabeth Hospital amounts to approximately $3.1 million in this current financial year. When you sum that total, you're talking about just approximately what, $183 million. Now, with $183 million, currently when I review the hospital's P&L, the hospital funding requirements are approximately in excess of $200 million. So before we do anything within the financial year and the forthcoming financial year, we will be looking at a deficit. Now that has implications for cash flow, and therefore the accounts payable at the Queen Elizabeth Hospital will always be a difficult exercise to manage. Having said that, we have to look and put our financial brains to work in an attempt to address the situation. How are we going to address the situation? We have to, first of all, secure additional funding for capital expenditure. We can't look at the 125 million to carve out any of that specifically for a 5-year or annualized capital expenditure plan. Because at the Queen Elizabeth Hospital, 70% of whatever is required is allocated to labor costs. So you start at a position where 70% is labor costs, and then you have to look at the other operating costs and utilities, etc. So in summary, we want to improve the accounts payable situation at the Queen Elizabeth Hospital. That can be assisted if we request supplementary funding from the government, and we can get that supplementary funding. If we can't get the supplementary funding, because we know that there are other government departments making a call on the consolidated fund, we have then to look at other income. And in the forthcoming financial year, we have to get back to a situation as obtained in the past, where the Queen Elizabeth Hospital was able to rake in at least $12 million in other revenue. And we now have to devise strategies to ensure we can enhance other revenues. Now, we also have a situation whereby there are persons who have healthcare insurance. And what I think we should do is we should have a situation at the Queen Elizabeth Hospital that encourages persons who have healthcare insurance to apply that healthcare portion to assist the Queen Elizabeth Hospital with their revenue enhancement position. And I think that if we can get that done, I think we'll be in a better position. But I can't guarantee that in the next financial year that we will not be in a position to pay all of the payables unless we start that gradual process of improving other income and improving other income as they did in the past, like I said. But we also have to start thinking about out-of-the-box commercial approaches. If we get a capital expenditure program approved, and we are able to reduce some of the recurrent expenditure that we have on, maintaining equipment that perhaps ought to be replaced some years ago, if we can start looking at other efficiencies. But I warrant to you that along with Minister Brown, Dr. Brown, that we'll be paying acute attention, and we are going to be putting all of our commercial and medical skills to work to hopefully bring this situation under some level of control. As I indicated in my opening remarks, the heads of departments will have to account for their spend, and we're going to have to be very judicious about that. The hospital is no different from a hospitality environment. It has occupancy, it has other costs, and we're going to have to start reviewing the costs, all costs within the Queen Elizabeth Hospital to see how best we can create a more efficient management system. So I will endeavor. I can't tell you that we will accomplish and pay everybody before the end of the financial year, but certainly what we will do is not to violate the program in the first instance, but we will try to seek out other revenue, other income for the Queen Elizabeth Hospital as we move to improve the standing of the Queen Elizabeth Hospital in the public side. Thank you.
Thank you. Thank you, Minister. I didn't hear a CapEx number that you're targeting for this year, but I do hear you that some of your decision-making seems to be a bit fluid in that regard. I'm happy to hear that you intend to settle the issues of financial management. Just to say quickly that based on some of my conversations with the small business sector, with the business sector really, I think that these matters are urgent. If we consider that these are companies that are supplying, in many cases, medical goods and services, we will then have to hope that they're able to sustain their good faith relationship with the government of Barbados or with the QEH, because the moment that they make a decision based only on their own profit or their own business decision making, then the people of Barbados will be in a bad position. So I just encourage us to try to be able to settle those issues because these are companies that need to prosper and grow just like anybody else. I'll move quickly to my second question, which is straightforward. We said a lot about surgical wait times for surgery and some non-surgical procedures, but I didn't hear much about clinical wait times. So this is to say that people who are referred from polyclinics, for example, people who just need to be seen by a specialist, what is happening is that appointments are postponed sometimes for an entire quarter, sometimes for 6 months. And these are people who have urgent issues, who in some cases are waiting for confirmation of a diagnosis that is potentially very serious. And you would understand that it would seem often to the patient as if these are kind of ad hoc decisions. So the person, it might appear, and please do correct me, I hope you will, that a person is looking at an appointment book and saying, well, I know that I do not have a clinician for this time. I have no idea what this person's issue is. I have no idea the severity or the urgency, but I'm just managing an appointment book, and so I shift this 6 months down the road. So I've heard the full explanation about surgical procedures, including cataracts, et cetera, but I want to hear something about what is happening, what is behind this issue with people who are being referred just to be able to have a consultation, and their appointments are being delayed and delayed. And I dare say that in some situations, they're delayed to the point where they're no longer of use to that individual, because by that time it is frankly too late.
Thank you, Minister. Good. Put it this way, we have been, within less than 5 weeks, we've been going through and reviewing operations at the Queen Elizabeth Hospital. We are looking at the outpatient clinics and how best we can improve the outpatient clinics. The other thing I would say is that the status quo at the Queen Elizabeth Hospital will have to change. We are going to have to look very carefully at how we deliver services and how we manage appointments. We have, and Minister Dr. Brown is currently leading a team to look at a new medical electronic medical records electronic system, which we hope to have in place soonest. But beyond that, the service delivery, and I think that's what you're hinting at, we have to improve it. The way to improve it will obviously will require us to engage in continued dialogue with the consultants, the physicians, and other persons at management at the Queen Elizabeth Hospital to make it happen. But what I would like to do before I come back to you is allow Dr. Clyde Cave, who's head of the who's the director of medical services at the Queen Elizabeth Hospital, to respond to you, and I'll come back, Minister. Sorry, Honourable Member.
Good afternoon. Dr. Clyde Cave, Acting Director of Medical Services. Thank you for the question, because our medical outpatient clinic has been one of our services that has had the most important and profound impact from COVID. To specifically talk to new appointments, which was a part of your question, all new appointments are supposed to be reviewed by a consultant and the appropriateness of the timing of the first appointment made. Subsequent appointments are handled by the house staff, and this is one area where we have employed telemedicine, which mostly is telephone contact. This really worked better when the country was under more severe shutdown. As we opened up more, having telephone contact with patients during working hours became more difficult. Our plans going forward is, as we have the return of our staff who have been deployed from the isolation centers back into the Department of Internal Medicine, these outpatient clinics should be revitalized. We are going to keep telemedicine as one of the arms, but we are considering extended hours of operation, and if funding allows, some of the private practitioners who assisted us in keeping the clinics going, they may be retained in a specialist capacity. Thank you.
What I would also like to add is that we're also reviewing operations of our outpatient clinics. I would have alluded to this earlier. We're looking to see if we can build out additional clinical space at the Queen Elizabeth Hospital. And if we do that, we're going to look and see how best we can either retrofit a space or acquire a new space in order to enhance delivery of patient care. Thanks, Honourable Member.
Thank you. My final question relates to the earlier conversation that took place on chronic NCDs. I recall that around 2018, we had quite a bit of conversation on specific programs or incentives for certain certain behaviors related to the management of people's health. One of those ideas that we developed had to do with this notion of a wealth for health approach, which is that you actually have, because of when you compare the high costs of care, of health care, particularly in this area, what we noticed, what we realized was that it would actually be more cost-effective and more efficient to offer certain kinds of individual incentives for certain kinds of behavior. And we discussed programs where people would perhaps wear something that is a watch, one of these smart watches that allows us and them to track certain behavior, to track their own compliance with drug and other treatment protocols, to track their diet and their activity, and to be able to locate that within an incentive program. And in lots of jurisdictions where it was tried, it worked very well, and it was actually more cost effective to the government. Similarly, a kind of conditional cash transfer within the social protection system, where people who are benefiting from certain kinds of cash transfers would also then need to be able to, and who are patients of the healthcare system, would also then need to to show certain level of compliance, not with burdensome things, but with the regular day-to-day actions that they have to take to secure their own health. I know similarly that the question of the cardiac care project also was around since 2018, and I'm hoping that we will now get some specific outcomes and timelines around that, because we have been hearing for some time what is planned, but I fear that we are not seeing what are the outcomes of that. But I wanted to ask specifically whether there is a concrete plan to use these kinds of incentive programs, not just to think about them, but to see whether there is scope to implement even on a smaller scale to start, because I do think that we have to start moving towards some concrete actions in this area. So I wanted to hear a bit about whether any such approach was going to be planned. There's much more that I could say about some of the approaches to these issues of people's behavior and how we frame things like childhood obesity, because I think that sometimes in the framing of these issues, we stigmatize the state of being obese rather than the underlying factors that have led to it. This is not the forum for me to go on these things, but I do think that when it comes to issues of how we approach labeling, how we frame some of these issues, that there's a lot of scope for us to perhaps review or tap. But I want to hear, please, if I can, about whether there are concrete incentives programs that are linked to that are linked to individual incentives or that are linked to cash transfers that can help us in this area.
Thank you, Honourable Member. And before we go there, I think it will be useful to have an intervention both from Dr. Clyde Cave and also Dr. Arthur Phillips. But before we go there, I think that you will be aware that the government in the current financial year would have started a community health worker program. And that program is meant to help us with the management of NCDs as well, which would effectively lower costs at not only the Community Hospital, but also other public health institutions. But before I go further, I would ask Dr. Clyde Cave and also Dr. Arthur Phillips to have a discourse on this matter. Dr. Cave.
Thank you, Clyde Cave, Acting Director of Medical Services. And thank you for this question, because the Transitional Community Care Program is one of the very few new clinically based programs that we have been able to implement during COVID that is not specifically COVID. Thank you very much to the Prime Minister who shepherded this program through by giving us a budget to run it as a pilot program. Now, to specifically address your concerns, there are many target populations of vulnerable people, and the population for this program is those patients who are already patients at the Queen Elizabeth Hospital with a chronic disease, mostly diabetes or cardiovascular disease, specifically heart failure. As the program, which was in operation for a year, has evolved, we have expanded to increase some patients who have amputations or wounds that need addressing, and also some patients who we have had to discharge from hospital perhaps sooner than we would want. So this population are the patients who are our frequent returnees and attendants at our outpatients and the Accident and Emergency Department. So the concept for this program was to develop a cadre of healthcare workers who can visit them in their home and, in liaison with their managing consultants at the hospital, implement the treatment, monitor the treatment, help educate further the patients and their families, assist in nutrition, exercise, and as you have said, encourage them to become invested in their own care. Many of these are older patients with chronic conditions, so the usual didactic kind of teaching doesn't work. This inpatient approach works very well. And from the first year, it is really encouraging to see that this program has borne fruit. Initially, because it's a new program, we had to invest quite heavily in the design of the program in collaboration with the George Eileen Chronic Disease Research Center and Professor Simon Anderson to build in monitoring indices where not only could it monitor the success of the program, but it would allow it to be publishable. And what we have found in the first year, where we have onboarded nearly 600 of these vulnerable frequent flyer patients, in that the exclusive visits to the accident and emergency department, which used to be very high, they used A&E as an outpatient clinic, those decreased to 26 only visits that were not part of a planned readmission or reassessment. And for those visits, they are accompanied by their designated healthcare worker who knows them. One of the other KPIs, the performance indicators built in, was readmission to hospital within 30 days of discharge. And for the nearly 600 of these highly vulnerable patients, there were only 4 admissions within 30 days of discharge. In my view, this is an incredible achievement, for not only will it increase the quality of care of these vulnerable patients and address the deficit in secondary care, which we have always known exists, but it really does help markedly reduce the burden on our accident and emergency department from these patients who really took up a lot of time and resources. Thank you.
I'll ask Dr. Arthur Phillips to come and weigh in on this issue as well.
Good afternoon. Thank you, MP Cattle, for the question in relation to the health grants and incentivizing healthy behavior. Absolutely agree, as you would have mentioned, that the causes of NCDs go way beyond the clinical issues and sometimes even the simple issues around individual behavior to the wider issues of the supportive environment. And one of the ways in which the environment can be supportive is by incentivizing the sorts of behaviors that we would want to see that would reduce the risk of developing NCDs and reduce the risk of progressing once NCDs have been developed. One of the concepts that we speak about when we speak about health and NCDs is the idea of social determinants and the reality that individuals' behavior is shaped by their environment, their financial, their physical, and other aspects of the environment. There is some evidence, as you would have mentioned, of incentives positively impacting individuals' behavior. And certainly, we've seen physical activity, healthy nutrition, and other aspects of NCD prevention promoted by use of incentives either at the individual level or at the level of healthcare providers who are interacting and engaged in preventive interventions. There have been some efforts in the past to provide tax concessions for individuals undertaking preventive procedures, the management and the pay and the actual transfers. So there is certainly potential around the idea of health grants, and we will look at how we can continue to utilize these concepts to improve our NCD burden. Thank you.
Honourable Member, you should also be aware that there is a draft concept paper in respect of incentivizing, obviously, to improve healthcare in Barbados, and that's at a very preliminary stage. Once that is completed, we will, and we get the necessary comments, we'll be submitting that information to the cabinet. The other issue as well that I should inform you about has to do with the school nutrition policy. That will shortly be going to the cabinet of Barbados as well to complement all the initiatives that we are going to be executing in respect of non-communicable diseases and how we manage healthcare costs going forward. Before we conclude, I would like to ask on this matter, I would like to ask the executive chairman of the Queen Elizabeth Hospital, Mrs. Juliet Sutherland, to address the matter as well.
Thank you, Honourable Minister, and thank you for that question. I just wanted to add, just to make a small intervention. Member Parliament Cattle, you are correct that it would be a seismic change in terms of thinking about the use of healthcare grants. And as our minister and others start looking at insurance and other models and new approaches to financing healthcare, it does lend itself well at that stage to looking at how we can build those kinds of measures into how we look at financing and placing some responsibility back on. But in this Honourable House of Parliament, I think it's also important that your question points to the fact that good health care, prevention of disease, is not just the responsibility of the Ministry of Health. It is the social determinants of health, early childhood education, food, as the minister just spoke to, access to housing and recreation, environmental pollutants, and other factors that impact on how people access disease and how people are impacted by factors that cause ill health. So my intervention is for this Honourable Parliament in thinking about how we can prevent the onset of chronic diseases, to take a whole of government approach and particularly invest in every minister and every ministry essentially becoming a minister of health and a ministry of health, and looking at how we can advance the agenda for the prevention of disease so that the hospital does not come, which is the highest cost center of your healthcare system, the recipient of the burden of carrying treatment of diseases that can be prevented by social interventions.
Dr. Brown also wants to make an intervention.
Just a small intervention, Honourable Member. We speak about incentives offered to the public with respect to NCDs, but I just want the public to be aware that there are other measures, almost negative incentives, if you want to call it that, where some jurisdictions have added to the taxation on sugary drinks. So on the one hand, rewarding a potential patient or a patient with financing, for instance, there are also the negative incentives, for want of a better term, where you put more taxes on some soft drinks, for instance, and sweetened drinks, where we insist by policy on labeling of items that are anti-NCD, if you want to call it that. There are incentives like that we can use to get the general public by policy to adhere to, just like we did for cigarette smoking. We put warning labels on alcohol ingestion, that kind of thing. So I think this is also going forward. I'm seeing it, and Dr. Phillips and us will work together with respect to forming policy to make some of these things law, where you have to basically increase the taxation. I think our taxation on sweetened drinks is extremely low, if I'm correct, Dr. Phillips, through the chair. So these are things we have to look at too, apart from rewarding patients, make it so that you basically have no choice. Make rules within the schools where you insist on a certain amount, beverages are not allowed over a certain quantity of sugar. Make sure that the vendors outside of these schools adhere to these rules. Of course, the school meal service plays a part. And as the Chief Executive Officer said, you have to involve parents and the other, as I said earlier, to the other partners in the ministry with respect to starting somewhere with the efforts, but we need to start from base, ground zero, more to speak. That's it.
Just to say thank you very much for those thorough responses. Dr. Brown, it feels so strange to call you Minister Brown, Dr. Brown. I hear you on the disincentives, but what we learn, in particular from behavioral economics and from understanding how people respond, is that you get perhaps a lot more mileage from rewarding good behavior and sending signals in that way than from punishing bad behavior. So perhaps there will be time for us, we talk about these matters all the time, you and I, so perhaps there will be time for us to explore that some more. But I want to thank you, ministers, and the colleagues in the ministry for your responses.
Minister, I know you agree, but that being said, it has been done. I think it's St. Lucia, correct me if I'm wrong, where they actually made it into policy and law that taxation be raised basically on sugary drinks. So while it works better to provide honey rather than something bad, these are things that we really have to consider. That's it. And Minister Brown is strange to me too.
Thank you. Thank you, Honourable Member for St. Thomas.
Thank you very much, Mr. Chairman. Good afternoon to all my colleagues and the distinguished members of the Ministry of Health, and I want to thank you for the privilege. I have 3 observations, and I would wish to first speak to, in short measure, to the community healthcare nursing that we have seen starting to revive again. Oh, this is impacted. I beg your pardon, sir. When we are limited in technology, you must forgive me, sir. I wanted to commend the government and the Ministry of Health of the initiative with the community health care program that has been, I'd say, reintroduced, because I knew it would have been in effect many years ago and it served an excellent purpose. And therefore, I think that it will continue to pay dividends, because we have thousands of persons across Barbados who, due to a number of matters, are unable to visit the clinics, the polyclinics. And I recognize that there are times when people are there to get in early, sometimes as early as 6 o'clock in the morning. And when the polyclinic opens, the younger folks usually get ahead of them. And then some of them wait until 2 and 3 and 4 o'clock. And it really makes it difficult, especially if there are persons who have challenges to do with diabetes and all that. And I think that the visits in the communities help. As a younger person, I knew of that kind of project going. And I knew when nurses and others came to the schools and tested children for vision, other impairments, the visual impairments, the hearing, and so on. And it really worked very well. But I know that many of our seniors, because of their comorbidities, they cannot get out to the polyclinics. And so in the same way, and I know that those visits will make a difference, especially those who have been released from the hospital and all that, and then they have to have dressings to get back to the hospital. They have to have transportation. They have to be moving around in the weather. Some of them have mobility challenges. And therefore, I think it is a wonderful initiative that will ease or eliminate the plight of families and caregivers when it comes to that. So I'm really very much in favor of it. And I must tell you that I have seen and witnessed some things happening at some of our health institutions, with the long waits and the negative vibes and the poor treatment, the insensitive comments that people are meted out to people, the intolerance, the frustration. It really is not a good experience. I, having had mine not long ago with an old man at one of the polyclinics, and I thought it was most unprofessional and disrespectful. And I'm not saying that this is happening everywhere, but that night when I went there, it really was beyond. And it was only God's mercy that I'm a Christian girl that I really did not kick up any dust, because I feel that people should be treated with the best form of professionalism, and that is not across the system. A lot of people in the system are cared for well by nurses and doctors, as well as the other members of staff on the compound, but I believe that some element of training needs to take place for even the ancillary staff in some of the institutions. I am not here to mention them because I'm not going to say anything disparaging about any area, except to say that across the board, there should be training so that people can know they are dealing with human beings who are the pillars of this society. By their sweat and their tears, they have built this society, and when the aged and the disabled go to some of those institutions, they're very poorly treated. And I want to thank those who came up with the vision, along with the Honourable Prime Minister, who forever was saying it, and my niggling ones, because of my old age, that I was able to talk about what I knew that a lot of young members in this honourable chamber are not familiar with, because perhaps they were in a position where they could pay the doctors and so on in the private settings, but there are too many thousands of people out there who rely on these services. So this is a wonderful step forward, and I want to highly commend those persons who are offering that quality service to our persons in the communities. My first query, though, sir, comes with the Albert Graham Center. And usually most of those persons who are disabled, who have to use those resources, are poor people, those who are most vulnerable and impoverished, I should say. And therefore, I am happy I was made to understand that last year there were some plans to have the facility upgraded. It had really run into disrepair for a while. And I wish to say how happy I am to see efforts being made that poor people's children can get the necessary support. I had looked and I saw in the estimates, and I'm not good at mathematics or anything, but I tried, just over $1.5 million last year, and I think this year it's going up to $1.795 million. And I believe that we should be really investing more. I had the distinct honor, I should say, while in the classroom, of teaching 3 children at different stages, 3 or 4 year period, where this one mother had 3 disabled children. And I saw the love and the care that she put in her poor way to be able to make sure that they met the needs, and the schools, of course, and others in the communities helping her. And I think it is about time that we pay more attention to our disabled in this society, making sure that their special needs are looked after. There's usually limited funding. Monetary support is not there in the same way. And of course, the parents cannot pay their way. So I am happy to see that there are some improvements. And I would wish to encourage the other entities, because I always talk about the synergies when it comes to the welfare department, and so that those children get the benefits that they deserve, rather than having to go on any list and then be eliminated because it is a review. These children need, and these young people and other clients who are disabled and have gone through the system, need to get the necessary support to be able to help to feed and to clothe and to look after them in the way that they should be. And I want to find out if the Ministry of Health is having closer synergies with the Ministry of Education, because all of the children are not impacted upon in any educable way. And I am a firm believer, as the slogan they had said, disability is not inability. And therefore, if the Albert Graham Center continues to work with the ministry, or starts to work in a more comprehensive way with the Ministry of Education, I believe that the mainstreaming within our system will help them to show up what their strengths are, and to help them through the system so that they can become even more independent as they move from strength to strength. So I would like to know exactly what is happening in relation to those synergies with education, and of course other agencies that will help to strengthen the bonds and to help to educate those parents of the disabled or those who are a part of that institution, because I think it is about time that the society not only looks after those who are at the levels of education at university and in the other schools, and so they need to spend more money and put more resources, I should say, human and otherwise, into the Albert Graham Center. And that is my first comment and query, sir.
Thank you, Honourable Member. And I do agree with you that training is essential and a very critical component of any future success of any entity. And therefore, the Ministry of Health will be continuing their training opportunities, and therefore, and will also be encouraging those persons to maintain the necessary training standards that they're used to and have become accustomed to. Of course, COVID would have interrupted some of our planned activities over in this current financial year. But as we move to manage COVID and we get back to the basics of managing healthcare, we are going to be emphasizing and re-emphasizing training opportunities at all levels, not only at polyclinics, but all throughout the ministry. In respect of sub-program 381, the Albert Graham Center, you are quite right, Honourable Member. You would have realized that there's an increase in the vote of almost proposed increase of approximately 260,000. And that is essentially to take care of those persons who are challenged, as you correctly identify. We cannot leave those persons behind. Their challenges must at all times be addressed. And therefore, after a review of the center, the ministry indicated in its estimate that it would require additional funding to upgrade the plant, and therefore we are going to upgrade the plant to the tune of approximately 260,000. Specifically, if you look at 751 on the plant and property, there's provision for 244,000, and also an increase in machinery and equipment for the center. There's an issue with the roof in the walkway that we have to fix in order to make sure that we make them as comfortable as possible, and we are going to do that. And also security system. There's an urgent need for security in that at the center, and we have proposed the increase there, and we will be executing that program once the estimates are approved. In respect of the Albert Graham Center, I would like to ask Dr. Ingrid Cumberbatch to give us additional details in respect of your question. Dr. Cumberbatch.
Thank you, Minister. Dr. Ingrid Cumberbatch, Senior Medical Officer. With respect, thank you for your question, Honourable Member. With respect to the Albert Cecil Graham Center, as you so correctly said, there would have been some renovations that would have undergone between 2019 and 2020. They, I think, were completed in 2021. But of course, as Minister would have said, there is still the roof and the walkway that needs to be repaired. The education unit, as you know, that is a component of the Albert Cecil Graham Center. But as you also very correctly said, the links between that unit and the Ministry of Education definitely need to be strengthened, and it has been something that has been identified, but I regret to say there's been not much work done in that at this point in time. So there's something that we're looking to do and endeavor to do in this coming financial year, strengthening the partnership with the Ministry of Education so that those persons and those teachers can have the support that they need, that Ministry of Health can't give them, but the Ministry of Education will be able to give them, so that they can improve their plans for the students of the Albert Cecil Graham. Thank you.
Thank you, Dr. Cumberbatch. I believe that would have answered your question, I hope. Honourable Member.
Thank you, Honourable Minister. Mr. Chairman, I also, for my second question, I want to focus on the alternative care of the elderly. And I feel that there should be a more holistic approach when the clients, the patients, if you want to call them that, should be transferred from the Queen Elizabeth Hospital, where they're occupying critical beds that will really be of great service to persons who require them, in order for them to be sent to the alternative care, be a part of the alternative care program. I know that the numbers keep climbing. I am extremely disappointed because there are persons in the system, meaning generally in Barbados, and some families who believe that they can just take their seniors and leave them at the hospital door, and it must be determined that they must keep them there because they can no longer look after them. And I know that it is really not an easy task if you have parents and guardians and others who are down with the dementias and the Alzheimer's and all that, and the challenges that you can have with them at home. It's not always easy to care for them, especially if that only caregiver is the only breadwinner in the family, so they're carried to the hospital, and I don't think that we should be taking our elders at all and leaving them there. And so I want to learn exactly what is happening, because the additional funds I see here again, it's about 150,000 more than last year. And I know that that is only, for me, a drop of water in the sea, when having had the experience to the last 3 to 4 years of numerous calls and visits, seeing persons who really require the alternative care, and the pensions that they're getting. Sometimes they get the non-contributory amount, which is just under $500 every 2 weeks. And then it really cannot pay for the services. And you know, the Honourable Member for Christchurch West spoke very profoundly about the kind of funds that would be required to care for those seniors who would be transferred from the hospital or from the various communities into the private homes. I know that over the years that we had meetings with the persons responsible for some of the private daycare facilities, as well as the private homes, and when we look at what they're receiving through government, is woefully inadequate. And so I would want to find out how we can go forward, and it cannot be just the Ministry of Health. I think there needs to be, again, closer communication and synergies with the Ministry of People Empowerment and Elder Affairs, because that is where every day there are no less than 50 calls or 50 requests for persons to be able to be transferred to those facilities or to be accommodated there. But unfortunately, there's no authority in the People Empowerment Ministry. And so I would like to be able to get word from the Ministry of Health as to how we can pursue going forward, acknowledging the kinds of challenges and the suffering that is taking place when seniors are left alone. And that we also acknowledge that our society is an aging one. And if our people are living longer, we are having more senior citizens that are becoming centenarians and so on. We really need to look at educational programs across the board. The Alzheimer's Association is doing quite a bit, but we need to have more use of the public fora, so families get to pick up when their relatives and so on are coming down with the disease and all that, in order to make a difference. We need to even focus as well on more facilities for respite care, because that is another area that we're having quite some concerns. And so I want to commend the government for the efforts, and to finally say through you, sir, there's a woeful lack of gerontologists in the country. And unless we have the National the National Development Scholarships, recommending persons and giving them the opportunity to do the studying, and then making sure that they're assigned to come back here and practice as a part of the contract, we are spinning top in mud. We cannot have so many thousands of persons, 80, 85, 90, 100, 106, only one last week was buried. We can't have that and not plan strategically to cater to the needs of our seniors when we have limited persons trained. I know that the Queen Elizabeth Hospital has some nurses that are in the program, but we need more gerontologists to look after them, bond them as we should with persons that have scholarships, that get the scholarships, they go overseas, not only those scholarships, but the ones that are given at the end of the secondary study, and then they never come back. And so the brain drain is there. And I would like to know what plans the hospital has, again with the Ministry of Education, to make sure that we have at least turn out 2 gerontologists every year, so that persons can get the necessary care. Not everybody is going to come to the hospital, but we would want private trained doctors and others at that level to be able to take care of our seniors, who really at this time, more than any other time before in our history, need to have the kind of care that is here. And so, sir, I would just like to have some reaction on that I can get some assurance that when I get back to the 450 people who I see on here every week asking about health care for seniors, that at least they can get an element of assurance that they know that there will be plans going forward, not only for their families, but for us as well. I am going over the hills, and they know that, and many of us are, and we need to know what is in place for us to get some care so that we can know our lives are safer and that we are in better opportunities to extend our lives in our right mind where possible, but with the necessary care to support whatever else happens thereafter. Thank you very much, sir.
Thank you, Honourable Member. Before I hand over to the Permanent Secretary to address the matter, I would like to agree with you that there are several issues in respect of the alternative care for the elderly that we have to look at. I think we need a policy position on this whole issue of alternative care for the elderly. And we have to start thinking outside the box and look at maybe futuristic concepts. We also have, in my judgment, to look at the whole issue of our senior living and how senior living could be incorporated in a broad policy to encourage persons who are often left at the Queen Elizabeth Hospital and elsewhere. Now, on that matter, I should like to inform you that at the Queen Elizabeth Hospital, we do have a challenge with elderly being left at the institution. On any occasion, we can have upwards of 25 to 36 beds out of what you call urgent patient care, because we have to care for the elderly. Now, there's a system that we have in place that we transfer those who are left at the Queen Elizabeth Hospital into the geriatric hospital and other hospitals. But the capacity at the bed capacity at the geriatric hospital stands at 278. And within the elderly, the alternative care for the elderly, we only have approximately 135 beds. Now, there are expanded opportunities, and I think there are expanded opportunities for even private sector people to get, private sector investment to get involved in, because clearly the government can't carry the entire load. But at the same time, we have a moral and social responsibility to look after those who've been left at our institutions. So we're going to work on a policy position. We are going to work with the ministry that you had the honor to lead, Honourable Member, when you were Minister. We will be working with several other stakeholders to devise such a policy, because we simply can't allow the Queen Elizabeth Hospital to become overrun with persons who've been left there. We have to keep it for emergencies and persons who are awaiting procedures to be done. But at the same time, we have a duty, a national duty, I might add, to look after our elderly, and therefore a policy position will be forthcoming. What I'd like to do is to ask the Permanent Secretary, the Most Honourable Jeanette Phillips, to speak on this matter as well. PS.
Thank you, Minister. For the record, I am Janet Phillips, Permanent Secretary in the Ministry of Health and Wellness. And Honourable Member Ford, you would have raised some issues that have been a concern for us in the Ministry of Health and Wellness. Certainly since I've been there from January 2020, we have been plagued with the issue, as the Minister would have alluded to, of having many persons left. We call it elderly fakir, and we also have a carrier of person called young fakir. These people are being left in the QEH, they're not being collected by their relatives, and then the burden then falls on the persons at the QEH hospital to manage them, as well as manage critical care persons. And it is an issue that we've been trying to grapple with, whilst trying to deal with the issue of COVID. We have put a temporary measure in place where we have now turned what was formerly the St. Lucie District Hospital. It had been had transitioned from being a district hospital to a quarantine facility. We've put it now as a quarantine facility for those persons, those elderly persons who have been left at QEH, to transition there until we can find spaces in the geriatric system. That in itself is still a challenge for QEH, and on a daily basis, we get the reports of persons who are left and they are clogging up the spaces, not only in the oxygen and emergency, but and they're also taking up valuable bed space that is needed for critical care patients. We are actively trying to renovate what was formerly the Elaine Canterbury Center. We're working on the roof. We're hoping to get it finished before the end of this financial year. So that will free up an additional 28 bed spaces so that we can help the QEH relieve some of the congestion of the elderly persons in the hospital. But you know, when there's a vacuum, then there's room for persons to then bring more persons. And the issue is a wide issue, and I agree with you, Member of Parliament, for that we need to have a really expansive educational program. You need to take care of your family, and if you can't take care of your family, then you work in collaboration with the Ministry of Health and Wellness to help them. But QEH should not be a dumping ground for old people who has labored and toiled in the fields and have sent us to school and made us men and women. People come and they dump their family members there and don't look back. And then they leave the whole burden on the state. It has to be a collaborative approach. And so therefore, we welcome the opportunity to work with the Ministry of People Empowerment and Elder Affairs. Honourable Minister for Ministry of People Empowerment, you will be soon hearing from Minister so that we can have discussions on how we deal with the elderly. The Ministry of Health and Wellness is responsible for dealing with the elderly who are sick, but those who can still be in the community and get help even from their neighbors, we need to put some mechanism in place to help them. I remember growing up and having elderly grandparents, what we would call grandparents in the neighborhood, but the whole neighborhood looked out for them. Back then, everybody in the village raised families. That is so absent these days that is so unfortunate, but we have to get back to that sort of approach where we look out for the elderly who can stay in their homes and just get some sort of assistance when they need people to check on them to make sure they're doing fine. And while we're at it, let me hasten to point out that we are very shortly going to be embarking on construction of a new geriatric facility at the Botanical Gardens, lovely spot. The aim is to build out 400 bed space capacity. We don't currently have that at geriatric, so there'll be room, Member of Parliament, for additional persons to be able to be housed in this facility when it's finished built out. It will not just for persons who are elderly for care, it will also be for people who want to have a retirement space there so that they can be in a conducive environment. So the plans are very well in train, and we're hoping that sometime next year we can see massive improvements in that area. You mentioned the whole area of respite care for persons with Alzheimer's, and I am happy to indicate that we are in the preliminary stages of having designs done for Alzheimer's respite care facility, which will be housed where the current Gordon Cummins District Hospital is located, because the few patients who are left there will soon be relocated to the St. Philip District Hospital when we have finished renovating some wards to house them. So we do have plans in place for that. They're at the preliminary stage. PM has indicated that she wants it to be a PPP arrangement where we build out and hand over to be managed, not by the ministry itself, but by private care persons. So we're working on that as well. You mentioned the increase in relation to the alternative care for the elderly. That increase relates to an increase in fees paid over to those persons for housing elderly care persons for us, because for the last 15 years we've been asking for an increase. We've not had any persons are crying out that the cost of taking care of the elderly has risen high, and we have responded to that. We didn't get as much as we wanted, but there's a start, and I'm hoping that next financial year we will be able to get a bit more so they can get fees more commensurate with what it takes to actually take care of a patient. Lastly, Member of Parliament, you indicated that there is need for more persons trained in gerontology. I'm sure that when I'm finished, the Executive Chair can speak on her behalf, but I know from my end in the Ministry of Health and Wellness, we're trying to put a training program in place where we have more nurses trained in gerontology. I know it's not a sexy area, but I know that it's still an area that needs to be taken care of, so we will be dealing with that very shortly. And have I covered, Madam, all of the areas that you've raised? I don't want to not answer any questions. Lastly, yes, I agree with you. We need to have gerontology as one of those specialties for the National Development Scholarship, and therefore when the circular comes around to the Ministry of Health, that will be one of the inputs that we'll be making. Thank you very much.
Honourable Member, I will also ask the Executive Chair of the Community Hospital to speak to this matter as well.
Yes, thank you very much. And I think you're correct, MP Ford, that there is a need for the training of more gerontologists and geriatricians, physicians who specialize in elderly care. And at present, the University of the West Indies Doctor of Medicine program does not have that as part of its repertoire of care. So it is something certain that we are going to have to fund persons to go overseas and train. I'd like to add, while I have the microphone, that in addition to respite care and daycare centers, we think the Ministry of People Empowerment, who has responsibility for driving the policy in this area, really should also look at issues such as carers' allowances. It is proven over time that if families can be provided with resources to help with the care of persons and keep them in their homes, that this will be much more cost effective to the government. This is done in England, Canada, and other parts of the global south. So there are a range of options for improving the care of the elderly. Certainly we will do our part to put in resources or request resources for the training of physicians and other staff in the area of geriatric care.
Thank you, Executive Chair. Thank you, Honourable Member.
Final one, please?
You're welcome.
I'll make it short. I know this is the one that is going to take away most people's hearts, because I find that our citizens seem to look at mental illness and scoff at persons who may, for whatever reason, have to have some kind of mental break or have to suffer from some form of depression. And I think it is something that needs to be removed from our psyches, because as far as I'm aware, anybody can have a mental break, have a depressive moment, and so on. And that is why, as a younger person, I chose to be a part of the bereavement services, because persons become depressed when they lose a loved one, when they lose their employment, when they lose even a pet sometimes, then they have to lose properties. And at this time, where we are going through COVID and so many people were unable to work and all that, they would have gone through some depressive moments. I've had about 4 or 5 within the last 2 weeks of persons whose properties are up because they could not go to work during the COVID time, and they're getting problems from the financial institutions. Some people, because they crop over, they're always fed kings and queens, and there's so many other challenges that are impacting on our people. And I would like to know what form of sensitization programs, beyond the few Zoom activities I've seen from the psychiatric hospital, that I always call the psychiatric hospital, as well as the district hospital, the outside children really in the healthcare. And I really shouldn't do that, but some of the things I see and know really make me feel that Barbadians must take a serious look at what we are doing when it comes to mental illness or aspects of persons who become depressed for whatever reason, knowing that each of us is a human being who could be here today in our right minds, and tomorrow whatever activity causes us to, or experience causes us to become more reserved and to become ill, that we would want to be recognized. And we know of many outstanding people across the world. I mean, there's one world leader now that I feel that he really has to be more than mental ill. With what we are seeing happening in another country that they have taken over, and all kinds of loss of life and so. And I would like to know what programs are being put in place for families and for the general public in relation to persons receiving the sensitization programs to do with mental illness, psychiatric matters, because we are seeing it every day, and with the upsurge in our young people and others who are caught in drug situations, or they've been made homeless and the depression kicks in. I would like to know, because I think that those kinds of programs will help families to better understand their roles, similar to what we are doing with the Alzheimer's Association and other forms of sensitization, to make the difference in the lives of others. And I have to close by saying thank you very much for all that you've been sharing with us, because at the end of the day, no one knows when it will get on their doorsteps or in their workplace, or in the churches or the institutions in which they have to function. And so I think it is everybody's business in Barbados to make a special effort to learn about mental illness, depression, and so on, and to be able to help those among them to mitigate those individuals having to go to the farthest extreme, telling them what signs to look for and how to treat to the matters to be able to make a difference. And therefore, I would wish to hear from those distinguished persons in the Ministry of Health, particularly those in the psychiatric hospital area, what are some of the things that are on the board to help us, because we've got the technology now, and for me, that will be wider spread for other people to be able to pick up the skills, and each of those institutions to form some kind of association of friends or something that will help to strengthen what the professionals in the institution will be doing to make a difference in the lives of all those persons who are impacted upon. And that is my general comment. I wish to thank you, sir, ladies and gentlemen, for their time and the experience.
Thank you, Honourable Member. I should let you know that the Ministry is currently working on a revised policy for mental health. And as I indicated in my opening remarks, we have to look at modern mental health strategies. We're aware of this is becoming, particularly during the last 2 years, an area of concern to Barbados. And we are definitely going to be working on and bringing that revised policy to the Cabinet for the necessary approvals as we seek to modernize mental health. What I would like to do is to ask Dr. Brian McLachlan, who is a senior consultant psychiatrist at the psychiatric hospital, to elaborate on this and other mental health related challenges. Dr. McLachlan.
Thank you, Minister. I am Brian McLachlan. I am the senior consultant psychiatrist at the psychiatric hospital. And thank you, Member of Parliament Ford, for your question. I think, as you have quite rightly pointed out, the past 2 years have been difficult times for all of us. We know certainly from international statistics and from anecdotal statistics here locally that there has been an increase in mental health conditions, anxiety and depression amongst them, for persons who have had challenges with regards to the pandemic. And this is challenges that are related to the physical aspects of the pandemic, as well as those related to what you refer to in terms of persons who would have had some socioeconomic fallout as a result of that. I will say certainly that the staff at the psychiatric hospital, certainly both doctors, nurses, and other paraprofessionals, have been involved in both providing care as well as providing, as you said, some of that sensitization that needed to occur. And because we had certainly some of our own internal issues with COVID, then we were very busy both working, but recognizing the need to also provide services to outpatients and persons in the wider community, as well as to provide sort of education and support for persons. What we're doing moving forward, certainly, and you may again remember, Member of Parliament, when you certainly were in ministerial chair, that certainly we would have again been in partnership with your ministry with regards to persons who had again been displaced by the hurricane and the tropical storm, and recognizing that persons so displaced from a home point of view did need services, and we did again partner in terms of being able to provide certainly some services as was required. We have also, since last year, we've been working with the Ministry of Education, recognizing that the whole issue of young people being out of school was creating quite a lot of difficulty for our young people, and wanting both to provide support, education, and services to young persons in our schools, but also those who are looking after them at school, that is our teachers and some of the ancillary workers as well. And we were able to provide some educational discussions, yes, on Zoom, but to both teachers, social workers and counselors that were in the Ministry of Education, and we were helped out in that matter. What we are hoping certainly to do moving forward, and obviously we're mindful that COVID is not quite finished yet, but we are looking past that certainly, and recognizing that people have had difficult times and still need support. We have always had, and we've continued to have, our community mental health services in the polyclinics. We recognize that during COVID, because of space needing for those sorts of services, that there was some displacement, but we recognize that persons needed help, and really the numbers who are attending those clinics had actually increased. And we are happy to serve, but we do recognize sometimes that the wait times are a little bit longer than we would want for them to actually be. We also certainly continue to have our services at the assessment unit at the psychiatric hospital, and we recognized again during the period that there was an uptake of persons who were presenting. We realized that persons, again, perhaps because of some of the displacement in the community and persons who would normally go elsewhere to access mental health services, did find themselves coming to the psychiatric hospital. You did hint at stigma where that was concerned, and that's always an issue for us. And that's something that we have ongoingly been trying to address as well. Our community services in general, and certainly our community mental health nurses, our community consultant psychiatrists, and we do have an in-hospital psychiatrist who are tasked specifically with doing more mental health education. And obviously we're using Zoom because it is what is happening. But as we move out of that environment, then obviously we're hoping that we're going to be able to do perhaps more face-to-face seminars and interactions. That's something we've always wanted to do prior to the onset of COVID. It's what we actually had planned to do in terms of providing a certain number of those sort of interactions in the community, wherever they need to happen, churches, schools, wherever. But we had certainly worked out that we wanted to increase the number of those that we actually do, and then COVID stepped in. And so I'm expecting certainly, because the need is there, that as time goes on, we are going to be getting back to doing a lot more of those sorts of interventions. October is usually Mental Health Month, and at that time, one normally sees quite a bit of a blitz in terms of information coming out through GIS and other media outlets. And what we've talked about doing is really not waiting until October perhaps, but trying to do a lot more during the year so that we do have a constant message of mental health and mental well-being that needs to certainly go out into the community. We realized with regards to persons who are coming into hospital with mental illnesses that because we had cut down on visiting, we weren't necessarily able to interact with families as much as we wanted to. And again, that's perhaps going to change as we perhaps may start to allow some more visiting at some point in time. But it's important certainly that once persons come into hospital that we do spend time trying to engage families, making sure that they're aware of what is happening, sensitizing them to what's happening as far as the particular illness that their loved one is suffering from, providing education and providing support, especially as those persons then transition out of hospital and back into the community. The last thing I will say at the moment is with regards to what we have hoped to happen, but which has not quite happened for a number of reasons, which is really to assist in the development of more support groups in our community, persons who will come together, perhaps service users, interested family members, really to provide support for persons who suffered with mental illness and mental health difficulties. We really would want for those groups to be formed, to be community-based, and we want that we'll be able to provide certainly education to those groups as opposed to us running them, because we do want, I think, the community to be able to help themselves, to be able to be advocates for what they need in terms of mental health services, and to be able to provide support for those persons in the community who need mental health care. Thank you.
Thank you, Dr. McLaughlin.
Okay. Thank you, Honourable Member for the City of Bridgetown.
Thank you, Honourable Chair. I want to start where my colleague and brother from St. Michael West started by commending the last Minister of Health, the Most Honourable Lieutenant Colonel Jeffrey Bosted. And I also want to say that when I look back with pride in the work that the Ministry of Health and Wellness have performed. But I also look forward with optimism because I'm very aware of the bodacious nature and approach of the current minister. I've watched what he's done with a number of agencies and ministries under his hand and how he's been able to transform, improve, and bring a sense of hope to the people of Barbados. I'm also very aware of his colleague that sits to the left from St. Philip North and what she brings to the table as well. So I look forward with optimism. With that said, I want to state that I've always looked at the Ministry of Health as really like a ministry of sickness, a ministry of treating sickness. I remember in another place, organizing youth parliament and looking at cabinet and asking myself, why should we name this the Ministry of Health and not name it the Ministry of Sickness? When we added the word wellness to it, I got a little excited because I said, we begin to get it now. We need to look at wellness and prevention. And we've spoken some bit to that this morning and this afternoon. But I want to go to the estimates directly in sub-program 40, the Health Promotions Unit. And to start by saying that while statistics can be a little dangerous, I see that we've almost doubled the amount that we're looking at in relation to health promotion. But that has doubled from 0.001 to 0.002. So we've gone and we're now looking at spending about $680,000 in order to look at health promotion. My question, Mr. Chair, as I consider what Dr. Phillips admitted is a bit small, is what are we looking at as a country and as a ministry in prevention when we're talking about health going forward? What type of behavioral change programs are we looking at? Who are the players in this? Is it going to be doctors? Is it going to be change agents, psychologists? Who? When I think of a Ministry of Health, just like the Executive Chair, Ms. Bino Sutherland spoke about, I believe that it should be a whole of government approach. What is the Ministry of Education doing? What is the Ministry of Sports doing? Ministry of Youth, Ministry of Information? What are we doing truly to bring a comprehensive approach to the prevention of the health challenges that we are seeing, costing us almost $500 million a year in relation to fixing these problems, many of which are preventable? So I want to know, in summary, what are we doing in a comprehensive way for behavioral change to prevent us having to spend this money?
Thank you, Honourable Member. I would also remind you that within the Health Promotion Unit, the unit is responsible for promoting healthy lifestyles, a comprehensive nutrition policy, and also encouraging healthy eating and obviously lifestyles. This is part, as I indicated earlier, part of our NCD program, a non-communicable disease program that we plan to execute based on the mandate given to us by the Prime Minister of Barbados. What I would like to do is to ask Dr. Arthur Phillips to expand on this very critical area. The sums voted will continue to help us to promote our programs within the ministry. Obviously, we would like to have received more funding, but we understand, the nature of revenue management. And therefore, we're going to have to look to other mediums in order to expand and communicate and message to the country in order to achieve the goals. Now, fortunately for us, we have social media. We have other social media platforms that we could utilize to get our messaging out. But the critical thing for us will be for us to get into the schools, working with the Minister of Education, to continue to promote the program that we envisage. The program will be an extended program, and even though the sums voted that we've requested and the sums that the Ministry of Finance would have agreed to in the proposed estimates would seem to be very small, we believe that we could use a process of getting into secondary schools, getting into the community to promote these programs, working with the ministry responsible for community empowerment to structure programs where we can get a lot of our field officers and other healthcare professionals into the community to help us spread the word. We believe that if we can do that, we would, I think, get greater bang for the buck, as they say. But at the same time, we would commence the process of encouraging persons to lead healthy lifestyles. So I will ask at this point Dr. Arthur Phillips to speak to this matter. Dr. Phillips.
Thank you, Minister. Thank you, Chair. The Health Promotion Unit has a challenging task in supporting all of the programs of the ministry in health communication, partner engagement, creation of healthy policy, promotion of prevention. Of course, key within that is the NCD support and support for not only the NCD Commission, but the work of the Wellness Task Force. And there is scope for, we have had in the past, a Cabinet Subcommittee on NCDs. We believe that even with the funds provided, as Minister would have said, I believe the figure that you're seeing in front of you is 680,000, but I've been informed by the Financial Controller that the figure is actually 503,000, as 177,000 has been adjusted away from that. So the Health Promotion Unit works in partnership with other ministries, and therefore we're able to extend the impact of the resources that we do have available. And one of the key means is by empowering persons through health education and through connecting them to opportunities. So the work there is large in scope, but we believe that given the technical resources that we have, and given the way in which the unit can collaborate with other partners, partners in the media, partners in the NGO sector, we can continue to have a positive impact. The issues in terms of the school nutrition policy, the issues in terms of the cancer prevention plan, the issues in terms of the NCD plan, all of these are tied into the work of the Health Promotion Unit, which also, of course, supports the work of environmental health, pharmacy, family health as well. So this work is going to continue to be key to advancing our efforts. We do believe that the unit will need to continue to have appropriate resources available to it. Certainly, as we submit the updated NCD strategic plan, we are going to ask for the resources to be made available to deal with staffing and building out and delivering on the NCD agenda. But as I said, health promotion has impact and involvement beyond health communication, and engaging with the NGO sector, engaging with the private sector, and helping individuals to understand how they can better live healthy lives through messaging and through incentivizing them and providing opportunities for them. That is going to continue to be part of the mandate of the Health Promotion Unit. Thank you.
Thank you, Dr. Phillips.
Thank you very much, Dr. Phillips, for that. For me, I've heard, you know, sometimes size doesn't matter. So what my greater concern is, and I'll move from, I wanted to ask a follow-up question, but I will move from that to basically begging that the ministry put some serious consideration or continue to put some serious consideration on the idea of prevention. When I pick up reports and I see 62% of beds at QEH are occupied by NCDs, preventable lifestyle diseases, I do believe that we can make significant inroads if we put a little bit more investment, time, energy, creativity, et cetera, in relation to prevention. Prevention, nothing to be scoffed at whatsoever. And I know that the ministry will continue its work in terms of prevention. I heard about the community health programs and all the other various educational programs, and all I am doing is taking this opportunity to make a plea that we continue to put some emphasis and increase the already existing emphasis on prevention. I move on to my second question, Mr. Chair, which is in relation to a situation that has been haunting me for some time, and I recognize that we did bring on a number of workers, temporary workers, albeit in relation to addressing the idea of COVID. And it's within these very honorable chambers that we, the public of Barbados, was educated in what temporary means. But I do understand that a number of persons were brought in to address COVID, and that as COVID now takes a shift into an endemic from a pandemic, we understand that there is some shift in the workers. I like to be forward thinking, and you know we have to do something with those workers. Just like in 2018, this compassionate government set up the household mitigation unit to address the number of persons going home, so that it won't be a case that we just sending home people, but that we put a platform to transition people into something, transition them into another form of livelihood. I want to know the ministry's plan. I want to be assured that we will not just tell people, wham, bam, thank you, ma'am, that we have some form of plan, some form of methodology for addressing these breadwinners, these single mothers, these people who have been gaining some form of income by putting into this country in its darkest time, looking after those COVID patients in the quarantine and in isolation units. I want to know if we have a plan to address the transitioning of workers, many of them from the city of Bridgetown, I will tell you, but also many of them that fall under my portfolio in the Ministry of People Empowerment and Elder Affairs as well. So I need to find out from the ministry what is the plan for those many, many workers who've helped us out over the last 2 years.
Thank you, Honourable Member. If you go to the program vote for COVID, subprogram 6201, you will note that as we anticipate the management of COVID, we will also have to look at, in a very wholesome way, how we manage issues. Now, I will say to you that no decisions were taken in respect of any of the facilities that we are currently engaged in, save for the ones that were contracted as quarantine hotels. Those obviously, based on the trending that we are seeing in respect of the positivity rate, we've taken the decision within the ministry, because obviously the resources that will be given to us in the next financial year would not allow us to continue with those. As we move towards the policy of home quarantine as well, that will obviously have to reflect the positions taken within the ministry. In respect of the workers at all the other facilities, like I said, we have not, Harrison's Point remains in operation. Yes, we accept that based on the trending, and if that continues, there will be an opportunity for us to look and see what we can do at the Harrison's Point. We have to explore, as I indicated in my opening remarks, what do we do with the Harrison's Point site? Do we look to create opportunities for joint ventures, and do we look for opportunities where we can maybe clear some of the backlog at the Queen Elizabeth Hospital, if it would allow, once we have a situation where the number of COVID patients there will be at an absolute minimum. So there are ideas that we're discussing, and we will look at those very carefully and have the appropriate responses. In respect of the other facilities that we have, we still have to manage. For example, we have workers at the Grantley Elms International, based at the Grantley Elms International Airport. They help us not only with flow of traffic, but they really help us to maintain port health at our borders. And port health is a very important and critical nature. So I can't tell you now, because obviously, based on how the estimates are constructed, we are continuing to manage. We are going to continue to manage the COVID situation. The Ministry of Finance, they have given us the appropriate resources. At the same time, we have to recognize that COVID has had a significant call on the government's budget over the last 2 years. And as we move to a situation where we're going to have to manage COVID, and we're going to have to work and live with it, we have to do so in a very sensible way. And Honourable Member, it is something that we will pay attention to. It is not a situation where we are going to simply be, engaging in any wholesale exercises. There are some facilities, obviously, that we will have to review in depth. But at the other time, on the other hand, we have to look at overall the facilities that we have in place and how best we can reposition those facilities to help us expand and upgrade and manage healthcare in Barbados. I will pause here and ask the Permanent Secretary to come in, and then I'll come back.
Thank you, Minister. Thank you, Minister. As Minister would have indicated in the estimates of expenditure, if you look at the errata that we received today, there's been a significant decrease in the quantums of funds allocated to the Ministry of Health and Wellness for the next financial year. If we check what was allocated in the current financial year, we are not even getting half of what was allocated, especially as it relates to 102, which is other person emoluments. That therefore has significant implications in terms of cost of salaries and how we can retain persons going forward. Minister would have correctly indicated that we have not made any definitive decisions in relation to all those persons who have been brought on for COVID, except in relation to persons who would have been working in the quarantine, catering for persons in quarantine. We no longer have anyone in quarantine. The decision going forward is that quarantine will not be paid for by the government of Barbados, and therefore any person who comes into country who has to quarantine will be quarantining at their own expense. We have expended significant sums in also paying for not only isolation facilities but quarantine facilities over the past 2 years. And as the DFE always tells me, the government no longer has this fiscal space in which to do so. And we as good civil servants have to follow suit. So the sums allocated under 102 for other personal emoluments, that's where we pay temporary officers, has been cut significantly. It does not even amount to a year's salary for those persons. So we are working in-house to make sure that we take decisions that we know the decisions that we make will impact, but we're trying to minimize the impact. We have not determined what that will look like as yet. Even though the positivity rate is coming down, we do not know what will happen in a few months' time. And we have been told by finance, if such a thing happens, when we have an increase in positivity rates and high numbers on the ground, then the financing will have to come, because our national response has to be one that is very impactful, as it has been over the past 2 years. So yes, MP, there are implications for labor, but I'm not at this point in a position to speak definitively on that. I can't, before to be put in naughty corner, we have to do it in consultation, not only with the two ministers, but also in consultation with the Ministry of Finance, who is the final arbiter. So some decisions will be made, those have not been made as yet. Persons who would have been let go from the quarantine facility, there are only 8 persons, and I'm not trying to minimize that, but they will be given what is statutory due to them. They'll be given a month's pay and loan notice, as well as any vacation pay owing to them, as is the custom and practice in the public service. Thank you.
Minister Brown wants to come in.
Just a small comment, Member of Parliament, and this serves as a source of comfort to me. One should bear in mind that some of the staff that were used during the COVID were transferred from the Queen Elizabeth Hospital and other areas, the polyclinics as well. So the public is aware of a shortages in staffing with respect to nursing care. And it serves as a source of comfort knowing that some of these people that were put toward the COVID effort are returning to their substantial posts. So that's, in essence, not a loss of job. The other thing I wanted to say, while visiting the Harrison Point facility, I noted that the Most Honourable Corey Ford had started, and his staff had more or less started a program, rather unofficial or otherwise, where he sought to train existing staff at every level so that they're more equipped to take on further workload, and the possibility of job seeking is there. For instance, he had taken people that had come on the lower level, orderlies and so on, and had trained them such that chances are, at least theoretically, they'll be able to fit into other areas within the public service or the Ministry of Health. So while the possibility exists that we may be cutting, bear in mind that some of these people that you're wondering will just go back to their substantive posts. With respect to the paucity of nursing staff, the public is well aware that we had issues with the no degree program at the Barbados Community College. And through measures that were taken, the pass rate now is like 75%, which is a great increase. So these would be nurses. We had brought in many, remember, from Ghana and Cuba. They're not meant to be long stay nurses, as far as I'm aware. So that being said, we have 4 years of nurses that will be equipped and well trained to take up positions where there is a need for them in the polyclinics and the hospital setting, geriatrics as well. Thank you.
I will also ask the Executive Chairman of the Queen Elizabeth Hospital to make a few remarks.
Minister, Chair, through you, our new Minister, Ian Gooding-Edgehill, has encouraged us as a hospital to develop, in addition to a 5-year CapEx plan, a plan for the staffing of the hospital. It is recognized that right now the Queen Elizabeth Hospital is not a 24-hour facility. And as we look to expand and provide services more efficiently and effectively over a 24-hour period, there is going to be a need for some additional staffing. But we want to do so in a rational way. We want to make sure we achieve all the efficiencies that we can achieve. And given our minister's background, he is intending, as I understand it, to look very scrupulously at what our plans are going forwards. So I do believe, Member of Parliament Ford, that the opportunity may exist, and as you heard Minister Brown speak, to transition. Corey Ford, it's on my brain. Minister Lane, that as we work with our substantive Minister of Health at our staffing plan for the hospital, there may be opportunities to transition persons. So once we do so in a rational way and within budgetary parameters.
Thank you. And just let me add, the Harsons Point facility, for example, that costs us about $1.1 million on average a month, or approximately $13 million per year to run. What Dr. Corey Ford has done down there short of remarkable in terms of training and developing staff. As Minister Dr. Brown had indicated, close to 3 Fridays ago when we visited, I must say that I was very impressed with persons who started there as an orderly and they're now enrolled in PAHO and other courses at the University of the West Indies Mona campus online. And for example, when I was there, I got an understanding of their client relations department. And there's no way that we would want to allow such talent that would have been trained and the levels of training to which they would have gone to allow that talent to go to waste. And we're not going to do that. We are going to work with, as the executive chair of the hospital indicated, once we have the areas where we have shortages and we can address those shortages, we will look at those very carefully and see how best we can realign human resources. But safe to say that the Ministry of Finance indicated to us that if we are in a position and we require additional funding, well, as long as we make a solid case to the Ministry of Finance, they will consider it. So at this point in time, I would say that we will continue to manage all our facilities as we respond to the management of COVID. And if there are any proposed changes that we have to look at or we have to examine of a financial or human resource nature, we will certainly investigate those and do what we have to do. Our goal is to continue to manage COVID. At the same time, we have to improve our facilities. And like I indicated, there are future plans. For example, I talk about the potential in my opening remarks for Best Dos Santos lab. I talked about future possibilities for the Harson's Point. And we also have to look at and see what we're doing in respect of the backlog of surgical and non-surgical procedures that we need to attend to. And therefore, once we put the plan together, I'm confident that we will be in a position to make the appropriate recommendations to ensure that we can utilize such facilities to help us to achieve our mandate in healthcare. Thank you.
Thank you very much, Minister and team. I feel a lot more assured. I feel better listening to the responses of the entire team. I pray and I hope that the many, many persons reaching out to me with a degree of nervousness that they too were listening, or that my team can clip the response and have it sent on to them. My final thing, Minister and Ministry, is the incinerator. The incinerator. I am here today to beg, to plead, to beseech for something to be done with the incinerator at the QEH hospital. 2 evenings ago, I sat here and watched my phone go berserk. The people complaining about the pungent smell. I know these things do happen, but it was particularly bad on Monday evening. I did some asking around, and I was pleasantly surprised to hear, well, it's in the estimates this year, only to have the proverbial rug tugged from beneath me. They told me it was in the estimates over the last 3 years. And then further to that, doing some more asking around, the rug not pulled now, pushed up on the ground, because they told me it was there for the last 13 years. I want Minister to beg and plead and ask the question what can be done, and if the ministry has even examined any modern advancement in incineration. I know we had a company knocking around here called Cahill talking about zero emission incinerators. I want to know what is the position with the incinerator in the city of Bridgetown. The only thing I could have done on Monday is to leave this place and go down there and sniff in solidarity, as the incinerator caused a number of issues, respiratory and otherwise. And I'm begging the ministry and pleading with the ministry in asking what more can this honourable member do?
Thank you, honourable member. First of all, it is always difficult when a member of parliament has to find himself in that situation. And we clearly, I understand, because I, like you, represent people, and they will on occasion put the case to the member of parliament, especially if there are issues that are considered to be a nuisance or bother to them. Honourable Member, let me indicate to you that the incinerator, as presently constructed, was there for a while. And since 2013, I believe recommendations would have been made for it to be, replaced. I'm happy to report to you that as part of the European Investment Bank loan, that we are going to have a new incinerator at the Queen Elizabeth Hospital. I cannot give you the timelines as I speak to you, but I can assure you that as part of that loan package, provision has been made for the replacement of the incinerator. For too long, we've been spending a lot of money on recurrent expenditure on the incinerator. It's akin to, as they say in where I used to work in my other life, it's like putting lipstick on a pig. And therefore, we have to part with that. So I will be in a better position once we are, once we have all the details in respect of the AB loan, to give you an update. And I promised you that I will give you an update when we're at that point where we can get it going. But it is a source of concern, and the Queen Elizabeth Hospital itself cannot continue to be paying upwards of $300,000 and $400,000 annually to just repair an incinerator that's past its useful life. This is one of the commercial decisions that ought to have been taken long before we were in government, since before 2018. But truth be told, it is what it is, but our mandate now is to fix it, and that we shall do. So I can assure you and the residents of the city of Bridgetown that a new incinerator will be coming. But like I indicated, I cannot give you the specific dates when we will start the construction, but I'll be happy to do so at a later date. Thank you.
Minister, on behalf of a grateful constituency and a grateful nation, I thank you.
Thank you, Honourable Member for St. Peter.
Thank you very much, Mr. Chair. I have a couple of questions for the Minister, or probably his officers. I'll begin, though, by recognizing the work done by ministry and hospital officials over the years. I think the work in addressing the impact of the pandemic is probably, history is probably going to show it as legendary. And I think we really owe a debt of gratitude to all those men and women involved in the fight to combat COVID-19 and its impacts. I also recognize the work done to improve in the accident and emergency department. And of course, a lot of commendation goes to the former minister. And I know the current minister, with his experience and his intent, will build effectively on what has happened before. I begin in terms of question where the Honourable Member for the city started. And that is sub-program 0040 of program 040, so the health promotions unit. I ask, from the perspective of being the minister responsible for the third sector, the specific question or the angle that I want to come from is to find out from the ministry, what is the intent? Is there any strategy or plan in terms of linking with third sector organizations? There is a mention in the estimates document of engaging and linking with stakeholders. I'm speaking specifically to third sector organizations. I'm aware that you do have relationships, particularly with those third sector organizations that are health oriented. I'm asking beyond those that we are familiar with. We heard some of them today: Alzheimer's Association, diabetes, cancer. There are other third sector organizations, and I'm wondering what strategy the ministry has in terms of engaging with them in the fight against the NCDs and any other health challenges that may exist in the country? That is my first question.
Thank you, Honourable Member. Yes, there is a plan to link third sector organizations as well as churches and other interested parties. Health promotion, as I indicated earlier, must be seen as something that cannot only rest with the polyclinics and the Queen Elizabeth Hospital. It must be extended beyond those public institutions. We have to get into the community as well, and that's why I said earlier that we will also work with the ministry responsible for community empowerment to help deliver the messaging that we need in terms of healthy lifestyle, nutrition, and so on. But I do take your point in respect of the third sector interest groups, and we are going to be working with those. I will hand over to Dr. Arthur Phillips, who will be in a better position to elaborate on the involvement of the third sector. Dr. Phillips.
Thank you. Thank you, Minister. Thank you, Chair. The Health Promotion Unit continues to lead on engaging with stakeholders, inclusive of the faith-based organizations, NGOs, the private sector, media, academia, cultural actors, etc. It's one of the strategies of health promotion to engage in partnerships and collaboration. The point being made that engagement should not be limited to traditional health partners, I think, is an important one. While it may seem easier to engage with NGOs and other actors who have traditionally been active in terms of contributing to health, there are significant benefits to be accrued in engaging with other partners. So that Health Promotion Unit engages with faith-based organizations. We actually have a document that speaks to how faith-based organizations can be engaged in conducting activities that improve health. We do engage with NGOs, and you'll be familiar with many of the NGOs that are active in terms of improving health. So you'll be familiar with the Heart and Stroke and Diabetes Foundation, Diabetes Association, Cancer Society, Cancer Support Services, and many others. In terms of the private sector, we do have partnerships. In COVID, we've continued to have private sector engagement. So across our areas of activity, whether NCD or as we've been focusing on COVID, there's a role for the private sector. This work of engagement is not always an easy work to do, but one of the things that we have committed to doing, and we have in our plans for this year, both from a health promotion point of view and from an NCD point of view, is to contribute to the formation of an NCD alliance. We believe that the NGOs in Barbados, while some of them have coalesced around issues of childhood obesity prevention, there's a wider NCD agenda, and that the NGOs working together can be more productive. They can complement each other's strengths and achieve more and collaborate with the ministry more effectively if they are organized through some more formal structuring across their units. Additionally, the work of the NCD Commission is intended to have that sort of multi-sectoral coordinating effect to it, where it includes the labor unions, it includes the private sector, it includes key government departments, and it helps with the understanding of and the influencing of actions across the various stakeholders that can improve health. At the higher levels, there is potential. We have had in the past cabinet level mechanisms for all of government NCD policy, and we believe that there is potential for this to contribute again. Another actor in this space has been the Wellness Task Force, and again, this mechanism has engaged not only the traditional NGOs, but the private sector, whether it be insurance companies, whether it be just large companies that can benefit from having an increased awareness of the benefits of contributing to the health of their staff and contributing more widely to the community. All of these are activities that are conducted and will continue to be conducted by the health promotion unit. So the sectors to be engaged, I take the point, it is an important one. We're not limiting ourselves to the traditional health NGOs. We are engaging with the wider actors to ensure that health is attained and maintained. Thank you.
Thank you, Dr. Phillips.
Thank you very much, Minister and Dr. Phillips. I heard mention of the NCD Alliance. The question I'd asked really had to do with the strategy. What I heard were what the plans are in terms of that we will engage with them. But I'm hoping, given that I'm making an assumption that the strategy may not be fully yet fleshed out, I am really pushing to say that there must be a strategy devised that would see that collaborative approach that is maybe at this point in the minds of those of you in the ministry. And I'm looking forward to seeing what the NCD Alliance will show. I maybe should mention at this point, since you mentioned the National Task Force on Wellness, I'll mention it here. I should have mentioned it to the minister before, but it's only now come to my mind, and that is that the ministry that I have the responsibility of leading has a relationship with the Ministry of Health in relation to wellness, and pursuant to Cabinet's approval about maybe 2 years ago of the National Workplace Wellness Policy, we established a committee that would focus on workplaces, working hand in hand with the Ministry of Health. We were very clear to set out that we are not into duplicating efforts or treading on toes. And so the ministry is represented on that committee, as well as the chair of the National Task Force on Wellness also represented on that committee. So that facility already exists, and I've instructed my ministry to know that we're almost in a post-COVID situation, to put some pedal to the metal where that is concerned in terms of its reviving, so that we are able to do our part in helping the Ministry of Health and Wellness execute on its mandate. The second question that I have is more parochial. It speaks to, well, I'm here asking this because of the people in St. Peter. And in Program 360, Primary Healthcare Services, sub-program 0408, this relates to the Morris Bay Polyclinic. I'm just asking questions maybe because of my background, I see utilities increase pretty significantly. And I'm wondering if it is pointing to something, maybe like increased hours, extended hours, because I see utilities mentioned in the current financial year that is coming to a close, 135.7 thousand, going to almost 206,000. And then I see supplies going from 128,000 to 216. The question I have is this a signal of extended time frames, expanded opening hours? Does it mean additional services being provided? What does it speak to?
Thank you, Honourable Member. At 4.8, the increases in respect of the account 207 utilities represents what is an accurate figure for utilities. It doesn't speak to additional opening hours. It merely reflects what we're actually spending in utilities. And what we did, we made a representation to the Ministry of Finance to bring it to its realization. Because if we have a situation where we are spending over 200,000, but we are only receiving maybe 130, 135,000, we will, at the end of the financial year, we will have to make a request for a supplementary, or as we have to do annually, or we will have to allow that bill to exceed the required number of days, credit limit days, and then deal with it in the next fiscal, and then we start off with a deficit. So this is essentially just a budgetary element to reflect currency in respect of utilities at the Mar.22-P2 Polyclinic. In respect of materials and supplies, it's the same principle applies. I've been advised that it has been under budgeted, and therefore the appropriate representation was made to the Ministry of Finance to bring it up to what we believe is an acceptable level. Clearly, you don't get everything you asked for, and we understand that. But that amount is to go to satisfy supplies and materials so we can maintain the required service delivery. Might also add that with rising costs, we are experiencing, this is across the entire ministry. If you look and see the cost of freight, when you even have to buy, for example, drugs, you're seeing an astronomical. I actually asked for, in the case of drug service, for an explanation, and I got that explanation. But this is reflective of what we have to do. We would have loved to have received more on the assets under construction, because we know that we have to replace the floor in the administrative wing. Obviously, we can't get that yet, but as progress is made with our government's revenue, and if we can make the appropriate recommendation in case to the Ministry of Finance, provided they have the resources, we will then seek to see if we can get an increase in the vote to undertake the necessary repairs. So as it is, the Mar.22-P2 Polyclinic, Honourable Member, will continue to operate as is. Thank you.
Okay, thanks. Well, at least I'm happy that the budget is now an accurate number as opposed to what existed before. My final question is, this relates to the emergency ambulance service. And I know that there are appliances, well, no, you don't call them ambulances. Appliances are the fire tenders. But at the Arch Hall Fire Station, I'm just curious as to what improvements has the QEH seen as a result of placing the ambulances at Arch Hall? Because I know they were placed there to allow for speedier response from calls from persons in the north of the island, north and east, I guess. So I'm just asking, well, north and northeast. I'm asking just for maybe an update, a little bit of a report as to what improvements have been seen. Has it been enough to cut down response time? That's really what I'm asking for. Thanks.
Thank you, Honourable Member. Yes, I have been advised by my colleague at the Queen Elizabeth Hospital that there is one ambulance at the Arch Hall facility. While we are on that, I should let you know that we have 7 ambulances on the road. We have another one to be procured via the QH's capital expenditure plan. There's also one that will be donated by, I believe it's the Maria Holder Trust, and that will be matched, that one donation will be matched by another by the government of Barbados. And then we are going to proceed with the replacement of another ambulance that was involved in a vehicular crash and was written off. So the proceeds from the insurance company will go towards the purchasing of an additional ambulance. Now, what I've also asked is that we look at a fleet replacement policy for the ambulance service, and we have to do that. And as you know, we already have 2 ambulances dedicated to the COVID-19 response. But specifically in respect to your question of whether or not we've seen an increase in the response time, I will ask the representative from the Queen Elizabeth Hospital, Ms. Brown, to address that matter. Sorry. Bob, sorry, to address that.
Louise Bob, Director of Support Services, Queen Elizabeth Hospital. And thank you for the question, Honourable Minister Jordan. And yes, generally the concept of decentralization within the ambulance service, it allows for a decrease in the call response times. The golden rule is to respond to emergency pre-hospital calls within the golden hour. That's the concept. And with the decentralization of our service to the Arch Hall fire station depot, it allowed us to have a faster response time to the calls coming from the north of the island. So between headquarters or Queen Elizabeth Hospital and headquarters and the response to the various parishes, the longest response time should be within 45 minutes. And with the Arch Hall assignment of our ambulances in that particular area, we've been able to keep within the 45 minutes, and under. We receive on a daily basis a matrix of data on how the ambulance service has been responding to calls from various parts of the island. So I can assure you that yes, the placement of a unit at Arch Hall has decreased the response times.
Thank you very much. I had a personal experience where I had to call an ambulance for a family member not too long ago, and the response was speedy, and I just wanted to find out, the reason for the question was really to find out if that was a common thing. I also should indicate to you, Minister and your team, that the paramedics were exceedingly helpful. These are not things often that maybe should jump out at you, but sometimes we get so many bad experiences in our interactions with people. But they were kind, they were compassionate, they were considerate. I don't often have interactions with paramedics, but the 2 gentlemen that I had interaction with were supremely professional, but also very, very kind. I would just conclude with a comment to say, Minister, that in relation to the Marsbell Polyclinic, we in St. Peter will continue to do whatever we can to assist. We don't have vast resources, but we've provided a television set for the polyclinic. We've also provided some picnic benches on the outside, and whatever we can do, we will continue to do to support that healthcare institution in the constituency and parish of St. Peter. Thank you very much.
Thank you, Honourable Member, for your contribution to the Marsbell Polyclinic, and also for your kind remarks in respect of the paramedics. Thank you.
Thank you, Honourable Member for St. James South.
Thank you very much, Chair. I want to start by congratulating the Ministry of Health and Wellness for their commitment, despite challenging circumstances, limited resources, limited staff, in seeking to keep this nation well and healthy. I know it is not easy. I just have a couple of questions. There are two areas that I'm concerned about that perhaps we have a gap in the service delivery that has an impact on a section of the population that we might need to address maybe some improvements as to how we go about doing so. The one area was the situation of where a family is dealing with a person who has a mental problem. Very often the problem gets worse and worse, and the resulting stress, both for the person who is affected by the illness and the family that is seeking to cope with the behaviors, seeking to get assistance from the mental health facility. There's a process, but that process seems to be challenging in order to be able to get the necessary care. And from my understanding, there's a shortage of resources as well, which exacerbates the problem. I have to thank Dr. McLaughlin for his assistance, because he was able to step in and help me with two of my constituent families that were struggling, trying to cope. I want to know what facilities and what resources are going to be available to further assist dealing with this particular challenge of mental illness, and whether that has been provided for to help expand or change how we approach dealing with people with mental illnesses and the support that we give to those families. That's my first question.
Thank you, Honourable Member. Indeed, I've heard about such situations before. What I would like to do is ask Dr. McLaughlin to address your specific concerns.
Good afternoon, Honourable Member. I can't actually remember those circumstances that you were just referring to, but I hope I can be of assistance now.
You dealt with them very well. Thank you.
Thank you, Honourable Member. I think let's start at the beginning. I think if it is that we have a family that is having difficulties with a family member, usually the first thing that will happen is a call will be made perhaps to our assessment unit. The family members will give information with regards to what's the concern, and if that's really the situation, it often means that the family members are not able to get assistance for the family member where the affected individual is willing to receive that help. And so if the assessment unit is contacted, then usually the community mental health nurse for that area will often be asked to go to visit and assess the situation, and usually then in a discussion with either community consultant psychiatrist for the area or myself as the senior consultant, then we make a determination as to what's the best next step. I will say certainly, and the reality is that what family members often want is for persons to be admitted to hospital, and to be admitted to hospital for a long period. Because, I'm going to keep coming back unfortunately to COVID, but because of COVID, where we have to be concerned with persons being admitted, having to quarantine, and mindful therefore that for persons to quarantine, we are using single rooms, and because we then also need single rooms for persons who are disturbed, and often people being admitted to hospital are disturbed, then there are challenges in terms of resources with regards to placement in hospital. And that's just the reality. So what we will often try to do once we are aware that there is a difficulty is, if there is space, if immediate space, then perhaps the person can be admitted. Otherwise, we do try to manage the situation as an outpatient, and sometimes that's successful and sometimes that is not. Perhaps because, again, we get different family members calling, or it's different days of the week, or sometimes the family members, they will call and they don't think that the response is fast enough, then they will be, calling persons to try to get additional help. Each situation is different, and therefore all I can say is I think if there are ongoing issues with trying to get appropriate and effective help for a family member, then if the reality is that it must come then to the clinical head of the hospital, then that's just the reality, or even the administrative head of the hospital, as in the hospital director. But often we would want that these situations are handled through the community services if it is, as I've said, the individual is not prepared to voluntarily come and seek help, either at the hospital, in its assessment unit, its outpatient department, or in the community at the community polyclinic, then it may be that certainly additional help is going to need to be borne to bear to get that individual the help that they need. Thank you.
Thank you for that response. And if we could make available to families via PSAs and so on, information on how to go about it, because by the time your entity gets to intervene, they are so stressed and so distressed that it is really challenging for them even to interact with you in a positive way, because they've really been stretched out by this process of trying to cope with someone who is not able to be mentally stable. So if I could make that suggestion. The other area would be the area of depression. It was raised by one of our other members. What I want to ask is, are there any plans, you may not have it in this budget, but if it is something that you're thinking about, I'd be glad to hear, because depression has been more widespread across the country, and I think over time our people have become more comfortable, should I say, or less negative about having depression and having certain stress conditions, recognizing that they need help. We need to have some type of hospice care where a person who is suffering from depression can go and get a step away from their situation and be able to get some kind of support, psychiatric support, psychological support, until they can recover their balance and learn to manage their depression better. My question is, do you have plans and resources, or is this something that could be pursued as a public-private sector partnership to look at providing some kind of hospice care for persons who suffer with extreme depression?
Yes, thank you very much. We'll ask Dr. McLaughlin again to respond. But I think there are some other clinical issues. I'm sure he would wish to respond to those as well. Dr. McLaughlin.
All right. Good afternoon. David Leacock, Hospital Director, Psychiatric Hospital. Thank you, Honourable Minister, for the question you posed relative to the matter of depression in the elderly and the need for persons to have sometimes what we call not hospice care but respite care. We recognize that there is a market there for persons in the private sector, for example, to come in and actually assist the ministry as far as this is concerned. We have explored possibilities of what we call day hospitals in the past, but there is not the resources at this point in time to explore that beyond that, as far as just the exploratory stage thus far. So we are hopeful that in time we can see public-private partnerships come into play to support the hospital as far as that aspect is concerned.
Thank you for that. And if perhaps we could, there may be other areas of healthcare that could benefit from public-private sector partnerships, and perhaps a publication in a public place of what some of those things could possibly be. It makes it easier for people to identify what are some of the things that they could support by making investment in those areas. My last question has to do with the whole digitization of records and making it easier for a person who has to interface with health institutions to not have to go back over their information. I want to know how far along you are with the digitization and what is being put in place, for example, to preserve the privacy of that data. Well, I know you would be looking at information sharing. What will be put in place in terms of data protection so that a person, yes, can get the necessary care and ease of care, because the health providers will have access to the information, but at the same time, what we put in place to protect their privacy so that information then does not become public for all and sundry to have access to.
Thank you, Honourable Member. I believe earlier in my remarks, I alluded to the fact that the Queen Elizabeth Hospital, working in conjunction with the Ministry of Health, and this is a project that will be led by the Minister of State in the Ministry, Dr. Brown. And the issue has to be that we have to move to a platform where we have electronic medical records. Now, not only exclusively available to the Queen Elizabeth Hospital. What we have to do is to have medical records with all the necessary security levels in place to protect what you just mentioned, data security and patient confidentiality. But we have it that we can extend it as well to the polyclinics. And I also think that in terms of our global reach, we should also consider expanding that facility to general practitioners, so that if there's a major medical challenge, you don't have to rely on hospital, or you don't have to rely on information being solicited from elsewhere, that you have in a central information system, that information being made available to all registered medical practitioners and all those users within the assigned security levels. We are going to work on that. There's currently a database program that we have in place, and I will allow Mr. Junior Burgess, who's the Director of Information Systems, to speak to this matter. But it is a work in progress for the ministry. It is urgent and very, very urgent, and we have already commenced discussions in the ministry. Like I indicated, Minister Dr. Brown will be leading that task, and the sole objective is to ensure that we have patient information in real time available to all public institutions, and with the requisite security access to persons in private practice as well. But I will ask Mr. Junior Burgess to speak to what obtains now and where we are likely to go as well in the future. But I would also like to say that in any system that we agree to, we're going to have to look at how best we can consolidate that information and store it in one place, and the whole issue of data analytics and how we control that. And in any event, any software that the government of Barbados should procure, the government of Barbados will have ownership of that software and ownership to make the necessary changes, because we will not engage in the purchase of any software program or database program without us being in control of that system. But I will ask Mr. Junior Burgess to speak to the matter. Mr. Burgess.
Good afternoon, Junior Burgess, Acting Director, Information Systems, Ministry of Health and Wellness. So Minister Gooden is correct in that we've started, when they say the QEH and the Ministry of Health have started to look at a system that will take care of all the needs of both QEH and the Ministry of of health and wellness. And what we've looked at so far does have a component that we can engage even private doctors, and we can share information easily. We are piggybacking off of what the Ministry of Innovation, Science and Smart Technology are currently doing with their modernization program. Whatever we do, it will be housed within their environment. So our data will be our data, be following the ambit of the Data Protection Act. We are looking at, in this situation, where the record of the patient belongs to the patient, and the patient determines who have access to that data. So they essentially give a person permission to access their data. And all of this falls under what the Ministry of Innovation, Science and Smart Technology is currently working on. We are far along with identifying what we want, where we would love to go. But as always, as we discussed for most of today, the challenge will be one of funding. Is the funding available to readily procure this system tomorrow and start the process? While I hear about how urgent it is, I want persons to appreciate that there's a process involved. We have to make sure that we do even change management to make sure that the staff in the environment understand what we're doing and they're brought on board. So there's not something that we can just flip a switch. Software is easy to buy. But if you buy software without engaging your stakeholders and going through that change management process, invariably sometimes you can waste your money because you don't have that buy-in. So we want to make sure as a ministry that we cover all angles, make sure that our stakeholders are involved in the process. And so far we've done that. We've had several meetings with our stakeholders. We've demonstrated. We've had a sandbox where they can play with the various packages. And then we make an informed decision as to which software package can give us what we want. But critical to that also is then going through conducting training for our staff, making sure that the infrastructure is in place. So all these are things that we're currently working on to make sure that when we do procure a system, that the system is fit for purpose. As my colleague said to me, there's no one software that fits all of our needs. And therefore, we know that we'll have to do some customization. There are the packages that we have in place, and to make sure that all these software can communicate and information is passed from point A to point B is critical. We started the process, great for us, and the aim is that in the quickest possible time that we will complete this process and ensure that there's a new system out there that adequately satisfies the Ministry of Health. One of the key things that we look at when we were choosing this software is the ability to mine the data within this software. With our current system, when we require information, we go back to our provider. But with the new software we're looking at, we want that we can mine the data on our own and then make informed decisions to guide health and where health goes. So I think we are on a good path right now. It's just a matter of ensuring that the funding is available and then working with our counterparts to implement this system and solution.
That was very reassuring. Thank you very much. And Minister, I just want to say to both of you, both ministers, that I really appreciated what was shared when you first opened about the effort to reduce the backlog of cases, because as an MP, that is a challenge for me, where people have not been able to get their procedures done, continue to suffer. So I was very, very pleased to hear that, and I look forward to the changes that will be made to help us deal with it, that people can anticipate timely and good health care here in Barbados so that we can keep a very productive nation. Thank you very much, both of you. And your team.
From us, thank you too.
Honourable Leader of the House.
Thank you, Mr. Chairman. Allow me, first of all, to express certainly sincere gratitude to the former minister for the sterling work that he has done in relation to the management of the Ministry of Health and Wellness, and certainly for helping us through the dark days of the pandemic into where we are. I know that he could not have done it without the strong team within the Ministry of Health and Wellness, and I believe that the country will continue for some time to owe a number of the persons, not just who are in the room, but a number of the healthcare professionals across the country, a debt of gratitude for the work that they've done to keep Barbadians alive. I want to just follow on from the last point that was made by the previous honourable member. who spoke, and I think other members spoke about it in relation to concerns about backlog of cases at the Queen Elizabeth Hospital. I heard the Honourable Minister and the team in relation to the steps that are intended to be taken to address the backlog, and I think that that is welcome because all of us echo the sentiment that this is a major concern across our constituencies. But I want to hear from the Minister and the team specifically about the rationalization of consultancy services within the hospital. And I ask that because there are a number of people who raise the issue that they attend the hospital, they're seen by a specific consultant, and then for one reason or the other, they're then told that it would be faster to be treated privately. If they can come up with the money, they can be seen by the same doctor outside of the hospital, or that arrangements, I believe, can be made for them to be seen at the hospital if they go through the doctor privately. I don't think that up to this point that we've really heard about how this expenditure is made in relation to consultancy services. I don't know if we have any data that suggests how many people the consultants are actually seeing on a regular basis, how effective the service delivery is, what is happening in terms of the number of patients who are actually turned away and who fall into that category where they are forced to seek the services outside or seek the services privately. But it is a growing concern for me because I feel as though we are paying for these services, but we are not necessarily getting from the public a sense that they are feeling as though the delivery of this service is working to their benefit. So I know we are turning the corner in terms of the pandemic. I know that this issue has been around for a long time, but I'm curious, Minister, from you and the team, how do you see the next few years in terms of being able to address the issue of consultancies and professional services within the Queen Elizabeth Hospital?
Thank you, Prime Minister. Let me say that you are correct. We are going to address the issue of backlog. Perhaps it's my lot that I like a challenge, and therefore I consider this, along with Dr. Brown, to be another challenge. And I give you and I give my colleagues and I give the country the assurance that we are going to work to address this issue. Like I indicated earlier, we can't address the issue in 1 year or 2 years, but certainly with certain specific objectives being set and measurable delivery being checked on a monthly basis, we are going to be in a position to understand progress. Part of the issue with the backlog as well has to do with the fact that the institution would have to benefit from additional capital expenditure. As I indicated back in 2019, the government of Barbados would have made available to the Queen Elizabeth Hospital some $18 million in capital expenditure, and that was well spent. We have to go a step further and make additional investments. But in making the investments in capital expenditure, we also have to do make some practical changes at this time. As I indicated, we've had approximately 700 or so persons awaiting cataract surgery, and we are putting a plan in place to address that. There are other surgical procedures that persons are trying to access, and we are getting an acute understanding of those. As I indicated earlier, I had tasked the executive chairman of the Queen Elizabeth Hospital to produce that information. As it relates to additional resources, once we have a look at the staffing levels and see where there are deficit areas at the Queen Elizabeth Hospital, we're in a better position to make a judgment and obviously an approach to how we need to resolve the issue. In respect of the consultants at the hospital, it is a work in progress. We've had a meeting with the medical committee. I will not at this time make any pronouncements. We are having additional discussions. The head of the director of the medical services at the Queen Elizabeth Hospital was there when we had, along with Minister Brown, when we had that discussion. So it's a work in progress. Once we've reached the stage that I can make a further public pronouncement, Prime Minister, I'll be delighted to do so. But at this stage, I know it is an issue, but there are several other areas that we have to address, including equipment, including making sure we have operating theaters operating at the optimum capacity, making sure that we have the staff to operate those theaters, and also utilizing other facilities that can perform some of these surgical procedures. So I will wish to say that at the appropriate time, once we've concluded discussions, we will be in a better position to do so. I also indicated in my opening remarks that we have a situation, and I do agree with you, where there's some persons who, and I said in my opening remarks, who went to school, worked hard, paid taxes to help educate those of us, and now they are in a state of pain, and we have to correct that. And it will take some time to do so. But I'm even more mindful that we have persons out there who have been waiting for an inordinate long period of time to get surgical procedures done. And it is my clear vision and understanding that we have got to address this problem. But there are several other areas and moving parts that we have to address. And once we've addressed those areas, I'll be in a better position to update you and the country in respect of the steps that we need to take. Now, the Queen Elizabeth Hospital, it is an issue of culture, and it's also an issue of processes. And we're going to have to change some processes without doubt. I'm not going to sit before you and say to you that we are not going to change. We have to change some of those processes. Like I indicated earlier, the status quo at the Queen Elizabeth Hospital will no longer be accepted. But we have to do it in a very judicious manner. We have to do it by involving the stakeholders and getting their input and addressing this long-standing issue. So I warrant to you, Prime Minister, and to the country that we will continue to have the dialogue and the discussions with the consultants and other members of the medical committee as we undertake a reform, urgent reform that is needed to address the whole issue. Now, once we can get we can reduce the backlog of cases, then we can start moving to a timetable. And that's why the implementation of a medical records facility, electronic facility, is so critical in this stage, because the hospital should no longer be requiring or asking of persons, consultant or other persons to check a diary or to check a log. We should immediately have a system in place that can tell us how long a patient has been waiting for a surgical procedure, how long they've been rejected or turned back, and why. And with that information, I think that would allow us to make more informed decisions. And if we have to make process improvements, we'll make additional process improvements. But I would say to you that that is the approach that the Ministry of Health intends to undertake. Thank you.
I want to thank you, Minister, for your candid response. I'm sure that you are also experiencing the same concerns and questions that we have as a representative. I hear you on what is planned. I want to know that the day can come where an individual in this country doesn't have to know an MP, doesn't have to know me in order to ask me to make an intervention to get an early date for a surgery, and a surgery that they perhaps have been waiting on for 4 years. I wish that we can get to that point, and I wish that we can rationalize the consultancy services that are currently available to the hospital, while at the same time being able to look at the overall delivery of patient care. But you touched on an issue of patient delivery and the execution of services to the public. And I recall, I think it was last year, raising this issue, having been a patient not so long ago. I was given certain assurances when I raised it that the Queen Elizabeth Hospital was going to be moving in a direction to focus on patient care and certainly the delivery of the services. I'm just curious as to what progress has been made to ensure that there is contact being made with the patients via the telephone, since in a lot of cases we cannot obviously have people physically in the plant in the way that we may have done before. What are the steps that have been being taken in terms of telehealth to improve the service delivery to patients across the country?
Thank you very much. In respect of, and I'll ask the Executive Chair of the Queen Elizabeth Hospital and also the Head of Medical Services at the Queen Elizabeth Hospital to respond. But in respect to the process of, and I think you're getting to customer care and service deliverables, the issue of, I went to Harson's Point and I saw what they have there set up, known as a client relations department. And it is one that engages the families, that kept them up to date in respect of what was happening to their relative or friend at the facility. We also had an opportunity for them to present to us how they executed. And I thought it was worth it to see the clarification, the explanation, how it works. And that, along with other clinical services that they offer in terms of getting back to clients. That is one approach that I think we could use. And there's also another approach, and this approach is used in, for example, United States, where you have a person who's responsible for first impressions at a hospital. In fact, if you had to go to a Baptist hospital, they have a director responsible for first impressions. I'm not suggesting that we have to use that concept or job title, but what I'm thinking about is that in terms of changing the culture and also changing the operating processes at the Queen Elizabeth Hospital, we're going to have to look and see how best we can fuse that and to deliver a customer service that not only keeps patients informed, but also has the extended capacity to notify family and friends. For example, what we've been through with COVID, we've had a situation where the hospital had to limit visits to the facility in order to protect its patient population. Now, a similar approach being utilized across all hospitals in Barbados, not only the Queen Elizabeth Hospital, for example, the geriatric and the psychiatric hospital, where we can have that outreach and that persons remain in communication with hospital officials. Like I said, it will take, I have a concept of it, and I think on where it should go. I have a concept but we first have to involve the stakeholders in the discussion process. But I do agree that the whole issue of customer service has to be fine-tuned. And once we fine-tune that so that we achieve the appropriate deliverables, I will bring, obviously, to the leadership of the ministry a little different perspective in terms, not because I spent most of my life working in the private sector, but I also believe that there's some things that we're going to have to measure and we're going to have to change, and that there's some things we're going to have to do in the shortest possible time. But I think overall, the goal is to improve customer service at the Queen Elizabeth Hospital by whatever department we call it, by whatever measurement. And it's not like a significant exercise. It's knowing what is required, what has to be done, and what we want to accomplish at the end of the day. I'll invite the Executive Chair of the Queen Elizabeth Hospital to respond as well.
Yes, thank you very much, Deputy Prime Minister and Minister, for those opening remarks. We have undertaken about 4 or 5 different initiatives, certainly to improve customer service, or we prefer to use the term to improve the patient experience. That is the term that's used within hospital parlance. During COVID, we would have established a help desk. There is a help desk. We're the only help desk in the country manned by physicians, EMTs, and nurses. And that help desk essentially was established first as an interface between families who are unable to obviously get access to their relatives because of the restrictions on visiting within COVID. And what we found, the response to that help desk has been so overwhelming that we've expanded it. It now runs from 8 a.m. in the morning until 10 p.m. at night. And that desk essentially is a critical interface between patients who are falling between the cracks, who are not getting their appointments on time. And because they're physicians or clinical staff, they're also able to intervene and advise. So we find having a clinically based help desk as a patient liaison service to be important. I think we have to get the word out more about that service so that people can be aware of it. Our ophthalmology department has also been one of the most innovative in the hospital in terms of telehealth and the consistent use of telemedicine. And they have actually piloted telehealth services for the patients that are in their facility because they're dealing with eye care. Perhaps they're able to do this. So we are actually utilizing telehealth and piloting a small electronic medical record system within the ophthalmology department, which is one of our most in-demand departments, so that we're able to, as we roll out, as Mr. Burgess would have said, we've addressed what are some of the cultural, process, security, and other issues that have to be addressed to roll out an electronic medical record system on a wider scale at the hospital. We also, within the accident and emergency room, recognized that we had some positions called patient advocates who had been functioning for a number of years, perhaps 7 or 8 years, Louise, or so. But we found that the public has been complaining significantly that that service has been less than stellar and less than responsive to their needs. So we've started the process of transitioning that service to a more modern customer service, logistics-based service, and that initiative is actually started and is underway. We also, in terms of improving the patient experience at the hospital, have started a process of rounding. What we do is multidisciplinary rounding between nursing, human resources, and other departments. We round within the hospital and meet patients where they are and find out what are some of the issues that patients are encountering, and then we're in a position in terms of case management to deal with them very specifically. Our bed management unit also has a component that involves case management. So when we encounter patients who are on the wards and say they've been awaiting, 3-4 days for a CT scan or some initiative that will result in delays in them being discharged or coming to a final diagnosis, that rounding experience is able to pick those cases up and address them. And finally, we recognize that we need to use technology more effectively. We've been exploring an application that we can use within the hospital where in real time we can have patients actually touch base with us and say very specifically, my bed is not working. I've been calling for water and the nurse hasn't responded. I'm here for 3 days and I'm still not clear on my diagnosis. So we are actually putting an application in place so that we can have persons respond, specifically the help desk, and another department respond to be in a position to respond in real time to the issues that patients are facing. So in a nutshell, Minister Bradshaw, we recognize that the patient experience is an area that we've been weak on as an institution, and what I'm highlighting for you are some of the areas that we've been making very specific interventions. What we do have to do is establish, in my view, a department that is fully accountable for this. It's referred to as a patient experience department in many hospitals, and we're looking to build that into the firm establishment of a quality unit so we're able to report using matrices that we establish on the patient experience at the institution. I don't know if I've missed anything, Dr. Cave, Minister, through you.
Yeah, I will ask Dr. Cave to assist as well. Dr. Cave?
Yes. Clyde Cave, Acting Director of Medical Services. Thank you for raising the whole culture of communication, which is not just confined to the Queen Elizabeth Hospital, dare I say the whole country. But as a hospital, we are interested in the communication between our healthcare providers throughout the team and our patients. And I think changes are required on both sides as we move to improve this. You asked specifically about things that are happening. From the medical side, One of the difficulties imposed by COVID was that a lot of our senior medical house staff were transferred to help man the isolation centers, leaving very junior doctors under the supervision of a consultant. And that made the decision making perhaps not always as clear and the response not as quick as it should have been. So what we did to augment that, we tried for volunteers, and that effort was stymied both by the ability of our technology, our IT within the hospital, as you've heard about, and COVID restriction, on people entering. But what we tried to do was to utilize a help desk that have now done 2 additional services. The first one, which was started a month or so ago, is for all new admissions to the hospital for their next of kin to be called the next day, to find out if the family is aware of the location of the patient. As you know, the visit in an accident and emergency and admission to hospital is much less than it used to be. To see the families aware and if they have any questions. And also, as a separate exercise, the help desk is doing a post-discharge satisfaction survey. This is in addition to our QEH Connect websites and the traditional complaints mechanism through our clinical risk department, which can be accessed in person, by telephone, or by email. But what we're really trying to do is to move from a complaints culture to a culture of promoting satisfaction. That requires the input from both our patients and our staff. We are very often told when we fall short. Very rarely do we get the feedback as to the things we're doing well. So these are what we have done so far. With the post-COVID environment, when we can return to a new normal, it is certainly our hope that the communication aspect will be one of the top priorities to address. Thank you.
Thank you, Minister, and thank you to the team for clarifying a number of the things that are in the pipeline. I will say, though, that I do believe that some of these things may need to be accelerated. A lot of the things still seem to be works in progress. And again, based on the feedback that I certainly receive from patients, people who are pretty much experiencing life-threatening illnesses, there is always a sense that that level of interaction, that perhaps at that point or juncture when people really need to hear a concerned voice at the other end of the line, or even when they visit the hospital, having persons to just reassure them, just talk them through the process, that still is very much missing. But I would again be hopeful that a lot of what is in the pipeline and certainly being contemplated, that there could be the relevant follow-through. I would also just like to suggest that perhaps some partnerships with other hospitals who have tremendous experience in this area, in particular the area of delivering on patient care and support, perhaps be explored in greater detail. It is important that we learn from the experiences of others. A lot of this, really, we don't need to reinvent the wheel. But I can say from a personal standpoint that a large part of my recovery wasn't simply my medical team. It was also the persons that I met as I walked into the hospital. It was the security and how they treated to me. It was the maids in the corridor. It was the nurses. It was the people at the front desk. And at every juncture, it made a difference in how you were treated in the place that people are going to get care. So I just want to emphasize that, if it has started.
Discussing with a view to obviously making some fundamental changes in terms of our Queen Elizabeth Hospital delivery has to do with the fact that I think we need to reach out to our diaspora. We have a number of Barbadians that I'm aware of, and since taking the office of Ministry of Health and Wellness, those persons have reached out to me, indicating their willingness to contribute to the hospital, and also some persons who have professional skills prepared to donate some of their time to the Queen Elizabeth Hospital and other institutions as required. It is important that we recognize that if we are going to have cutting-edge technology, that we're going to have to reach out to the diaspora to help us. I also think that, and you're on point, that we should also work with other institutions abroad. Currently, the Queen Elizabeth Hospital works with Northwell. There is a relationship there. And I think that what we have to do is that we have to expand our partnerships throughout United States of America, for example. There are multiple of institutions, medical institutions, who are known to Barbados, and I'm sure who will be willing to assist us. Take, for example, the whole issue of capital expenditure. There are hospitals based in the United States who change out their equipment sometimes within a year, within 2 years, because they want to remain on the cutting edge of technology. And I think if we have good partnerships with those institutions, we perhaps will be in a better position to procure some equipment that we could probably use in Barbados at very reasonable rates, or even reach out to them and encourage maybe some of them to donate some of the equipment, as has been done in the past, because it's nothing new to the Queen Elizabeth Hospital. So I do take the point that we're going to have to reach out. In respect of with partnerships, in respect of the medical aid scheme, the figure in the forthcoming year's estimate is provided for at 1.228 million, the same figure that we would have had last year. I can tell you that since becoming minister, I've had the opportunity to sign off on emergency care for at least 3 persons to be either transported via air ambulance to Martinique or to the medical facility in Colombia. That program continues to work well. The doctors do a splendid job at the Queen Elizabeth Hospital. When there's an urgent recommendation, they contact the Ministry of Health. We get the paperwork sorted out, and within a short period of time, we get that sorted, so that the persons would no longer have to worry about urgent care, and that they would be transported. Like I said, there's one situation I'm aware of, a young person being airlifted to Martinique, whose surgery was successful. And that is about one of the many success stories that the QEH medical aid scheme continues to cater for. And I hope that we will continue. Obviously, as government's revenues improve, we will want to ask for additional sums. But as it is working, it's working well. And I believe that we will have to look at partnerships throughout, so that we can perhaps even achieve external assistance at a reduced price. I'm not sure if Dr. Clyde Cave, Director of Medical Services, would want to add any comments to this particular topic of the QEH medical aid scheme.
Thank you, Minister. This is always a difficult one of being all things to all people and how you balance it. The medical aid scheme is designed for treatments not available at the Queen Elizabeth Hospital or on island. For context, you have heard the amount in the scheme. The very complicated medical cases that sometimes will arise, a single case can use up that entire vote. So we have to balance not only the medical aspects of the case, that is the prognosis and the likelihood that this will make a difference, that the treatment is indeed available and available to us somewhere, and we can access that, and not just a choice by patients as to an alternate facility. But then we also have to manage the purse strings. It's done on a case-by-case basis. Once the referral comes to the hospital and 2 consultants agree that this is something that should be done, cannot be done here, then it works its way through the ministry. Thank you.
Get out of cave.
Thank you, Minister, and thank you to the team.
You too.
Honourable Member for St. James North.
Thank you, Chairman, for this opportunity to intervene in this very important aspect of policy of the government of Barbados. First, wish to publicly congratulate the new minister of this portfolio, and I know he has the character and maturity to do well in this position as well. This is the first opportunity I have on this floor to, however, commend the previous minister, the Most Honourable Jeffrey Bostick, the former member of this Parliament of the City of Bridgetown, for what I regard as essentially heroic work that he did in leading this ministry during the COVID pandemic especially. And you know, I wish him well in his retirement from elective politics. I also wish to, of course, commend the team of the Ministry of Health for their tremendous and significant work over the last 2 years especially, and in helping to keep as many Barbadians residing here as safe as they have been able to do. The issue, Mr. Chairman, of funding of the Queen Elizabeth, well, not only the Queen Elizabeth Hospital, but health care on the whole in Barbados is central to this debate, and of course central to the ministry's proposal for estimates for the next financial year. And I would like, well, maybe perhaps the minister or permanent secretary to go in to a bit more detail on the issue of funding in terms of possible health insurance, insurance of persons who come into contact with our healthcare institutions, Queen Elizabeth Hospital, etc. And I know this has been mooted and toyed with over the years. In fact, the Honourable Prime Minister, when she was leader of the opposition, I think it was 2016, gave a speech to one of the professional organizations in healthcare that I thought was certainly up to that time the best analysis of healthcare funding and insurance for it that I had heard put forward by anyone in terms of this country. I know that you know, our main focus has been COVID over the last 2 years, but I am wondering, Minister, what is your ministry's policy position on this aspect? I mean, people who have health care, health insurance policies, for example, who go into the Queen Elizabeth Hospital, whether their health insurance policies are accessed for their health insurance providers to pay the Queen Elizabeth Hospital. I know that certainly that was a proposal. I believe there was certainly a decision to implement that kind of policy. I don't know if it was ever implemented, or if indeed it was implemented, if it is carried out, so that the government and by extension the taxpayers of Barbados can recover some costs, and if indeed there is no such implementation, whether there's any overall policy on health insurance for the general population of Barbados. Other countries do it, of course, more developed than us. For example, Canada has had that in place for decades. So I'm just wondering, Mr. Chair, if the country could be told a bit more on this aspect.
Thank you, Honourable Member, and thank you for your kind introductory remarks. And let me just take you back a second. I went over it before, but I'll take you back a second. The Queen Elizabeth Hospital allocation in forthcoming financial year is 125 million. The government would have announced a health levy, and that health levy currently will pay over to the Queen Elizabeth Hospital, and this is the one administered by the National Insurance Scheme, approximately 55 million. Obviously, because of reduced economic activity, it fell from its original high of about approximately $62 million. Other revenue to the Queen Elizabeth Hospital will be approximately $3.1 million. So right away, you have a picture of the Queen Elizabeth Hospital, okay, receiving approximately $183 million from those three sources. Based on preliminary numbers and estimates that we have, in order to run the Queen Elizabeth Hospital, it would take more than $183 million, okay? If you had to factor in a capital expenditure program, and which ought to be factored in any investment in healthcare, it would run you probably in excess of $200 million. What I can tell you is that at the Queen Elizabeth Hospital, for private patients, the issue of applying patients' health care insurance is done. What we have to do, and we have to get better at, and this is what we discussed as soon as I joined the ministry, is a regime for allowing those who have private health insurance for the hospital to access the private insurance through their cards if they swipe, or through their respective carriers, in order for us to generate additional revenue for the Queen Elizabeth Hospital. And that's one aspect of it. The next aspect we have to look at is generating additional revenue, as the hospital done, and I have been advised in the past, where the hospital used to collect in excess of $12 million per year in other revenue. We're going to close this financial year with approximately $3 million, and that is not good enough. So we have now to review that, and we've started that process to implement a plan to see how best we can move that $3 million and ratchet it back to where it ought to be. And whatever the number is it 12 million, 15, 10 million? I don't know, but certainly we want to see the curve on the upswing going in the right direction in respect of other revenue. The other thing that we are working on is, and Mr. Danny Gill and Dr. Clyde Maskell, and Mr. Danny Gill is the Health Finance Commissioner within the Ministry of Health. And they have, before we joined the ministry, they have been working with the health unit at the St. Augustine's campus of the University of the West Indies to look at the health indicators and the metrics to see how best we can improve those. We have all the data, and we are currently working with that small team. In addition to that, we've also been reaching out to others to see what is obtaining in the marketplace. In respect of a national health insurance plan, that is also something that we have to consider. The issue has to be in the construction of it. Is it that, therefore, that there is a national scheme, or that we partner with others? Now, there are other aspects to look at that. For example, claims experience and all the other metrics used and benchmarks used by healthcare carriers, health insurance planners, in respect to how we do it. But I can assure you, Honourable Member, that we are looking at it. I was advised by somebody who sits on the Queen Elizabeth Hospital Board that approximately 38% of Barbadians, they have health insurance. And if that is the case, we have to find ourselves in a position whereby we can leverage some of that to benefit the Queen Elizabeth Hospital. The government of Barbados cannot, based on all that is happening, continue to support the hospital at the levels, because there are others, ministries who would require a call on the consolidated fund. We have other projects that we like to use. So we have to look at the balance. We have to sit down and analyze how we spend money at the Queen Elizabeth Hospital as well, because we cannot continue to spend money in ways that will get no returns. And that is something that has engaged my immediate attention, along with Minister Brown, So we are going to analyze it, we're going to work on it, and we are going to do so bearing in mind that we have to deal with matters relating to the Queen Elizabeth Hospital. I'm not sure if I've answered your question, Honourable Member, but we are moving in a direction to see how best we can continue to shore up the revenue streams for the Queen Elizabeth Hospital.
All right. Thank you, Minister. Before I come to my second issue, I just want to say I support the aspect of the intervention by Honourable Acting Prime Minister on the issue of surgeries and the delays, and the whole issue of consultants and having to pay. If you have the money, you can get surgery quicker. This is something that arises every year during the exercise of debate on the estimates. And I know, Honourable Minister, you said that it is being worked on, but I too support the Honourable Acting Prime Minister's call for this whole issue to be speeded up. I know it is obviously a challenge because of the pressure that the hospital and the whole health services are under, but it is obviously and clearly a concern to our constituents where they have delays in operations. Second issue, Speaker, if I may be allowed.
Sorry? Did you like me to respond? Sorry, I wasn't sure. Oh.
Well, I was still going on to ask my second, and maybe you could respond after that. The issue of rehabilitative care for persons with disabilities in the healthcare service. Again, I know that we're doing perhaps as well as we can do in terms of the rehabilitation, but I'm just wondering if we, this House and through this House the public can hear a bit more in terms of what systems are in place for rehabilitation of physically and mentally challenged persons through the Queen Elizabeth Hospital or otherwise. Because clearly as we go on, the percentage of people with these challenges is increasing in our country. The capacity to sustain a disability is increased through obviously motor vehicle accidents, and the more motor vehicles we have, and this is clearly something that we should address our minds to, as well as of course being able to identify challenges of mental challenges of our young people in schools. I know that in the last Barbados Labour Party administration, or rather the one under the Right Honourable late Owen Arthur, with now Prime Minister, in fact, and the Honourable Member for St. Thomas in the Ministry of Education, we would have had assessments of I think children from age 4 in terms of their abilities and whether they had visual problems or hearing problems, diagnostic analysis of whatever challenges they may have. And I know that certainly in our 2018 manifesto, we committed to bringing that back on after it was terminated under the last Democratic Labour Party administration. And therefore, you know, my intervention here is on the issue of people with disabilities and what this ministry is doing to make life better for them.
Thank you, Honourable Member. In respect of the backlog situation, I would address that in my opening remarks. Like you, I'm a representative of people, and I know that this is a major concern. You would appreciate that Dr. Brown and I, we've only been on the job for 5 weeks, or less than 5 weeks actually. And immediately, as soon as we got there, we went to work trying to distill a lot of information, practice the art of discovery to understand what was happening. I think we are in a position now where we know We're just awaiting additional information on the additional waiting list for surgeries. Once we get that, we're in a better position. Now, respect, for example, and I'll go back to the issue of cataract treatment and surgical procedures. Once now we have the information, we're in a better position now to put things in place to act and to make a difference in the lives of people. And that is what we're about as representatives of people. I came to public life to do that, and then I've done it before, and I will continue to do it along with Dr. Brown. So we are going to deal with the matter, and like I indicated, what I will do, we will, at stages, we will message and communicate progress to the country so that they know at all times. We are exploring, as I've indicated, a number of other opportunities that I think, for example, if we are renting a facility, we can look and see how best we can utilize that facility to have a surgery. Now, I'm acutely aware that there are individuals within our society who cannot pay between $4,000 and $6,000 for a cataract surgery for one eye. And I'm also acutely aware that there's some persons who have to go and leverage their personal finances and property in order to get that money. And I know it's difficult, and I empathize with them. And therefore, it is my mandate every day I go to work to see how best I can improve, along with Dr. Brown, the processes at the Queen Elizabeth Hospital to ensure that patients get the care that they deserve. And that's why I said before in my comments that the status quo at the Queen Elizabeth Hospital will no longer be obtained, because we don't have time for that. But what I commit to you and other members, that I will, at the appropriate time, give you an update once we have distilled all the issues and once we've put a plan in place to remedy the situation. In respect of healthcare financing, I would like to ask Mr. Danny Gill, who is the Health Finance Commissioner, to address this issue in a few minutes. And thereafter, I will ask the head of the Queen Elizabeth Hospital Department of Medical Services, Dr. Clyde Cave, to address the issue of patient care as it relates to the physically challenged. Mr. Gill.
Danny Gill, Healthcare Finance Commissioner. Thank you, Minister. I think we need to put the whole topic of healthcare financing within context. It is part of healthcare reform. Previously, we had gotten a cost, which was a grand total for what it costs to run the healthcare system, both in the public and the private sector. That was about $734 million. Then we decided that we needed to cost each program and activity within the healthcare sector. But that was the public side. We did not do anything on the private side. And the Health Economics Unit at UWI St. Augustine was contracted to do that. And they did produce a report. For instance, they would have used 2017-18 as the base year for the costing, which means that if we want to use these average costs that we now have, we would have to, as the minister alluded earlier, to look at the cost index that Dr. Maskell had put in, Ambassador Maskell had provided for us, and bring it up to date, up to 2021. And that would give us, those are the costs now that we would charge or that would be incurred to deliver a service. Now, for the total, based on the study, what I want to highlight here is that the QEH took up 56% of the total cost, which would have been about $371 million. And that is based on the study. The polyclinics, 10% of the cost. The district hospitals, 9%. And the others and the other programs would have accounted for the other part of the percentages. During our costing of the health services, that $734 million, what we discovered is that 39% of our population was paying for their services, their healthcare services, out of pocket. And I want to emphasize this because it is telling us, because basically WHO is saying it should only be about 20%. we were 19 points above that. In the next survey that we did around 2016-17, that figure rose to 43%. So we had gone higher. And what is this all about? When an individual goes to the QEH, and someone at the QEH tells them, we cannot do this at the QEH, but if you come to the private sector, we can do it. That comes out of that person's pocket. So when that person is selling the car, when the whole family is putting this together, that is out of pocket. If this continues, it could be as much as 50%. What this is saying to us is that based on how funding is now done, because the majority of it comes from tax revenue, as the minister said, some of it comes, a minor part, from health insurance, and Barbadians tend only to use that health insurance plan to do something where they have to travel overseas, or if it is costly. For instance, cancers and the various costly diseases that you would have to think. The other part of that comes out of pocket. So it is something we need to address. So basically, what we are, and as he indicated, a small group, what we are now looking at is how do we go forward and how do we fund healthcare in Barbados. One of the avenues we have is government through its tax revenue and other measures procuring the set of money that is needed to run the healthcare service and dedicated it to that. I've already said to you that right now is not working. The other option is to look at healthcare insurance. For instance, I've been looking at a number of countries in the Caribbean, and there's a particular country that I'm interested in. And what they started with, they actually started by doing a health insurance plan for their hospital. And in the next part of it, what they did is that they brought in what we now refer to as our polyclinics. So there are two things that we are really looking at in terms of how do we go forward. And we are looking specifically at how would we, what is that form of funding that we would use to fund the QEH. Dr. Maskell is looking at one aspect of it, and I'm looking at another aspect of it. And we hope to have something to bring to cabinet. But I wanted to, if there's something that I wanted to make sure that we really garner from here, is that when a person goes to an institution and we tend to be saying, oh, care is free, someone has to pay for that free care you're getting, even education. And when we did, what we actually did when we did this, before this study, we actually had some community discussions, and the majority of persons in Barbados agreed that we should go to some point where the individual starts to make a contribution to the delivery of the care. And that right now as it stands is inescapable. Thank you.
Thank you. Dr. Giff?
Well, switching gears to the whole question of rehabilitation, which is a very large and extensive area, which traditionally the Queen Elizabeth Hospital was not part of the original vision and mandate, but as healthcare has evolved and expectations have increased, it is now part of what we must do. You know, originally the QH was an acute tertiary care institution, and rehabilitation comes secondary. To speak to the psychological or mental health aspect, there is very limited role of that at the Queen Elizabeth Hospital. Our psychiatric unit is an acute unit, and our outpatients are of limited scope and capacity. mental health services are offered in conjunction with the psychiatric hospital. We are, however, seeing an increased demand for mental health hygiene, rehab, assessment, if you will, both for members of our staff who have become increasingly stressed, and health within the workplace includes psychological health. And throughout the country, there is a demand for rehabilitation from substance abuse, which has not been a direct part of the Queen Elizabeth Hospital, but obviously it interfaces when that affects physical health, because they're not always as neatly separated as we would want to be. Physical rehabilitation is also a huge area. As far as children goes, that's the purview of the Albert Graham Center for Child Development. But we have undertaken, particularly in the newer developing areas of psychology, school performance, suspected child abuse and neglect, all emerging areas that are requiring interventions that are closer to rehab than to acute tertiary care, and that's certainly an area for development. We have, over the last several years, opened a stroke unit, but the management of strokes is more than just the admission to hospital. It would certainly involve resuscitation, rehabilitation, speech therapy, occupational therapy, and this we have limited resources for even while in hospital in the acute unit, and there is certainly a role for discharge into the community. Rehab extends into the prevention, and you've heard discussion here with the diabetes and cardiac programs, getting ready to deal with advanced disease. Our amputation rate, which is the most extreme kinds of cases, we do offer limb replacements on a limited basis, but this too is a service that has lots of room for growth. Our physical therapy department, originally designed to be supportive for our inpatients, has expanded its role and now has a large outpatient client base. And the need for working in the community for our acute rehab with community-based rehab is an area for development. We have been looking at a potential role for the most vulnerable of patients through our transitional community care program, and there is a lot of opportunity to expand the original concept of diabetes and cardiac care and comorbidities into physical and even psychological rehabilitation. I say all this just to highlight that this is a tremendous need, part of which is being met through our acute tertiary care mandate, but a large part of which needs to be developed through interface with the community. Thank you.
Thank you, Dr. Cave.
Mr. Chairman, my final intervention would be on the issue of illegal substance abuse and its effect on essentially the operations and of the psychiatric hospital. I know that issues related to the psychiatric hospital have been raised during this debate, but I know when I was Home Affairs Minister, we would have had discussions with the Ministry of Health and Wellness and Ministry of Youth Affairs. The Honourable Member for Christchurch West Central was Minister of Youth Affairs then, on this issue, and trying to bring this whole aspect together because we don't operate in silos. And I was just wondering what policies or proposals going forward the ministry through the psychiatric hospital may have, obviously in association with other ministries, for trying to limit the amount of people coming into psychiatric hospital as a result, either directly or indirectly, of abuse of illegal substances.
Thank you, Honourable Member. I will ask the Senior Consultant Psychiatrist, Dr. McCaughton, to address that point.
Thank you, Honourable Member, for that question. The issue of substance abuse has, again, historically been a challenge for us, and obviously the use of illegal substances in the country, which creates issues in their own right, but then perhaps will also cause secondary mental health issues and mental health conditions, which then require treatment. During the pandemic, one of the things that persons who work in substance use would have reported were that there appear to be more persons who are presenting with substance use issues, and understandably so. Persons would have been stressed, and therefore there would have been an increase in the use of the commonly and still commonly used drugs of alcohol, marijuana, and in some instances cocaine. And this is even sometimes despite the attempt to prevent persons from getting access to alcohol. What would have happened, and how our services, certainly our mental health, our substance use services are organized, we would have at the hospital traditionally had a day program, but our residential drug rehabilitation and treatment, we would have partnered with the Substance Use Foundation, and therefore clients would have been referred to Verdon House or Marina House, depending on their sex. And during the pandemic, those services did continue. There was an effect on our rehabilitation services in the hospital as a day program, because obviously being in groups proved to be a bit of a problem. And so services then at the hospital would have been primarily about assessment for those persons who then did want to go on to residential services and residential treatment, which did continue through the pandemic, with the use obviously of protocols and testing to ensure that persons in those facilities were safe. So moving forward, certainly as time goes on, we're expecting perhaps to be doing a bit more in the hospital as far as having treatment services concerned. Again, once we can manage the protocols and keep persons safe. Expectation of continuing partnership with the Substance Use Foundation for those clients that definitely will need residential services. We partner with the National Council on Substance Use as well. They provide both counseling services, and so we have worked with them in terms of education and providing education for, again, community and public officers and the like, in terms of issues related to substance use and abuse. And the hospital also is associated with CASA, which is an outpatient substance use facility that provide counseling and have moved into some counseling with regards to mental health matters as well. And so we expect that these linkages will continue, and especially as we come out of the pandemic, then we expect that there is going to be greater utility of all of these services. Thank you.
Mr. Chairman, with your leave, I was going to ask if it was at all possible that if I would allow the head of the laboratory services just to make a few comments. The reason for that is that the head of the laboratory services, Dr. Sanju Beckles, has spearheaded Barbados' efforts in managing and helping us to do all the required testing at the Besto Santos lab. But I think it will also be useful for Barbadians to understand, beyond COVID testing, what is done at the Besto Santos lab. Grateful for your allowance, sir.
She can proceed, Honourable Minister.
Thank you. Dr. Beckles.
Good evening, Minister, and good evening, Honourable MPs. Thanks for giving me the opportunity to speak and just say a little bit about the Besto Santos Public Health Laboratory. So I think everyone knows us mainly for COVID testing, and we have been spearheading that effort over the past 2 years. But the lab itself, before COVID, we were in existence. We actually the amalgamation of 3 public health labs, and our services are quite wide. So outside of COVID, we support not only the Ministry of Health in the different public health sectors, but also in some of the other departments for some of the testing that we do. So for example, we are responsible for doing a lot of the water quality testing in partnership with the Barbados Water Authority and the Environmental Protection Department. We support several other programs within the Ministry of Health as well. So we do in terms of surveillance for other diseases such as influenza. We also look at the arboviruses as well, which includes the mosquito-borne diseases such as dengue, chikungunya, Zika. If you remember, we had outbreaks of those as well. So we still continue to do our surveillance for those organisms as well within our daily testing. The molecular department that is responsible for doing COVID testing does quite a lot of other molecular tests. We also support the HIV/AIDS program for HIV monitoring, doing HIV viral load. As well, in the past, we had done HIV drug resistance monitoring. We also supported in doing CD4 testing. I must say, though, a lot of our services, because of COVID and logistics and the access to some reagents on the market based on the global needs for COVID testing, we did have quite a few disruptions. But we are actively in the process of bringing all of our testing back on stream. We also do other things such as assay testing. We also assist in the diabetic monitoring by doing the HbA1cs for the polyclinics. In terms of the antenatal testing, we do quite a lot of the swabs from our testing for the polyclinics to make sure that our antenatals are doing well, doing other STI screens such as chlamydia and gonorrhea. We support the cancer monitoring program through the fact that we can also do HPV monitoring, or HPV testing, I should say, at the laboratory as well. So the lab is vast in terms of its capabilities and the actual operations and services that we provide. We also do air quality testing. So our lab is not only just medical, but we also do some environmental monitoring as well. As the lab continues to expand, we know we've heard throughout the COVID pandemic, they talk about sequencing for COVID, and we have used CARFA as our main source to be able to determine or to help confirm what variants were actually in Barbados at the time throughout the different waves. We've also done some molecular tests that can specifically identify the variants without doing genetic screening. But we do think that genetic screening is still also very important. In our efforts as we go forward with COVID as well, we have actually been able to acquire some of the equipment to do the genetic screening, and through the Living Lab, which is a concept of a new lab, a research arm to the Besto Santos Public Health Laboratory, which we hope to get on stream within the next financial year. That is one of the first tests that we are hoping to get up and running, and this will be important in surveillance. So find COVID it seems to be minimizing a bit in the community, but how do we continue to monitor going forward? And our efforts will be to get that test up and running so we can at least see, and for our positives as we see them, that we can actually do genetic surveillance to see if any new variants are coming, or just have an idea of what is actually circulating in Barbados. So that is one of the main things. But that facility is envisioned to do a lot more. We spoke here about some of the other areas in health that are extremely important, such as cancer diagnostics. And this lab is also destined to be able to facilitate that, to look at genetic markers that are specific for cancers in our population. And its base and its push is really coming from Barbadians in the diaspora who are willing to give back to Barbados, and they have helped us develop the concept of the Living Lab, and they're willing to come in and give their expertise and to help develop the capacity, technical capacity and training of persons here in Barbados to be able to do this testing so that it helps us to understand what is going on, not just with COVID, but with some of these other NCDs that affect us tremendously here in Barbados. So in a nutshell, just to give that gives a snapshot of what we do, and we will continue to build, and we always look to see what else we can do to improve services and laboratory services in Barbados, and actually reach out to the healthcare providers to see what is needed, what is changing in Barbados, how can we respond, and we will continue to work in that direction. Thank you, Minister.
Thank you, Dr. Beckles.
Thank you, Honourable Member for St. Andrew.
Thank you, Mr. Chair. As recently as last year, we would have seen the refurbishment and reopening of the St. Andrew Outpatient Clinic and the St. Joseph Outpatient Clinic. Now, I want to say that the people of St. Andrew are certainly very grateful for this facility, especially in the context of an exodus of services from St. Andrew. But since the clinic was open, and I speak subject to correction, but it has only been open, it only opens 2 days a week. My question, therefore, is what are the immediate plans in terms of staffing? I imagine it must be a staffing issue, but what are the immediate plans for that facility in St. Andrew? And I suspect the same thing applies for the facility in St. Joseph. In terms of having that facility open 5 days a week so that the good people of St. Andrew can have access to the services 5 days a week. And my next question, you can answer both. Mention was made of the Elaine's Canterbury facility, which is on the same compound. I know that it's being refurbished. At least I heard that the roof is being repaired, but can you just shed some light on the plans for that facility in terms of the arrangement that will be put in place when it's completed?
Thank you, Honourable Member. You are correct. The facility at St. Andrew, the clinic, when it was open, I believe it was open last year, there was an arrangement for the clinic to operate 2 days per week. In the new financial year, we're looking at the prospects of having it open more than 2 days. However, the issue of additional resources, we can get the nurses, but we now have to have an arrangement in place to ensure that we have the doctors stationed there. So I can tell you that we are actively working on it. I cannot give you a specific date when we will move beyond the 2 days, but I will commit to you that the time has come for it to go beyond 2 days, and we will, I'll work with the permanent secretary, who's the accounting officer in the ministry, to see if we can have the resources available, and if we have the resources available, we will certainly try to move it in that direction. Thank you. Of the Elaine's Canterbury Center, I will ask the permanent secretary to address that matter. Thank you.
Thank you, Minister. As I would have alluded to earlier, I don't know, I speak very quickly, so perhaps everyone didn't hear me when I said it. We are currently renovating the Elaine's Canterbury Center to use it as additional capacity for elderly for care. The first intention is to get those persons who are currently taken up by space at the QEH out of there so that we have additional capacity for tertiary care. And so the intention is to get persons there once the roof has been renovated, the capacity it can hold is additional 28 persons, so that's the intention for the Elaine Scantlebury Center.
Thank you, Permanent Secretary. Can't hear you.
Oh, sorry. What I wanted clarity on was whether the intention was to use that facility for the benefit of the people in that community, as opposed to be an extension, being an extension to the hospital. So that's really where I wanted the explanation. But I think I understand clearly what you just said, and I do wish to tell you that there's persons within the St. Andrew community, namely the church, who would have expressed interest, because you would have said something along the lines that the idea is to renovate the facility, but have another entity or someone else manage the facility. So I was wondering how that would gel, if that is indeed the case, if it's going to be used as additional beds for the hospital, but at the same time, discussions being, there's a discussion around having another entity or company or group or what have you operate the space. That's why I thought that we were looking at bringing that into use for the benefit of the community. But as I said, I'm thankful, Minister, for the efforts that are being made, being proposed in the new financial year in terms of bringing more resources to that clinic. People are extremely grateful, but at the same time, we would wish to have access to it on a more regular basis. Thank you.
Thank you. I'll ask the Permanent Secretary to respond to the comment as well.
Honourable MP, pardon me if I misled you. I wasn't aware that you were speaking about the building that is immediately beside the St. Andrew Outpatient Clinic. I was speaking about the Elaine Scantlebury Center, which is currently located in St. Lucie. But you were speaking about something else. Am I correct?
Yes. The building next to the clinic as the Elaine Scantlebury
Yes,
Center.
which was a former St. Andrew's Children's Center. That's what you're referring to?
Yes.
Oh, sorry. So we were talking on two different wavelengths. I know that we had initial discussion, and certainly you were part of the conversation last year when PM would have opened the new outpatients clinic, indicating that it should be put, the former building should be put to proper use. There was just that initial discussion. We were not able to go any further from that discussion right now, but I'm sure that Ministry will be amenable to receiving some proposals from entities who might be desirous of using the space and renovating it and using it in a PPP arrangement. So, Honourable MP, if you have any suggestions, feel free to send them our way. Thank you.
Thank you, PS. Will do. And sorry about the mix-up. That concludes my two questions. So over to you, Mr. Chair.
Thank you, Honourable Member for Christchurch East.
Good night. Thank you very much, Mr. Chair, Honourable Ministers and your representatives. You've had a pretty grilling time, and I think you've acquitted yourself well. There are a few questions I have. Discussion was had about a fund to deal with services that are not available in Barbados, or not readily available in Barbados. And I accept the explanation you had, or you gave, insofar as the question was posed. But what is concerning me is, for example, categories of treatment like replacement surgeries. So, for example, I hit replacement surgery, which I understand that the QEH does not do, or the government does not provide for. But what about persons who are in need of such surgeries and simply cannot afford it? I I think that we need to move away from just seeing amputations as being the option. I think we need to move away from just the emergency treatment, but for somebody who has a hip issue or a knee replacement issue that is living with that pain daily and it is actually crippling them, then giving them drugs and painkillers is not the answer, and there must be some answer. It cannot be that we're in that gray area where we can provide no support for you. I just want to know what would somebody, or what facilities are available for somebody in that position who has been diagnosed or recommended for a hip replacement surgery and who simply is not in the position to pay for it. Is it our contemplation that their answer is a life of pain?
Thank you, Honourable Member. I will ask Dr. Sonia Brown, Minister of State, to address the issue.
Thank you, Minister. Thank you, Honourable Member. You are correct in stating that the operations for joint replacement have not been done in several years. I think we're going back fairly far. Several years. I think the last one was 2012. I stand corrected on that. Some of the issues we have are similar to the other issues with the other theatres, in that the availability of theatre space, the unavailability of nursing staff, hip replacements and knee replacements, joint replacement is a very specialized area within our orthopedic surgery, along with trauma surgeries and so on. Right now, the last set of replacements we did were classically the old way, the ball and socket joints. As I learned yesterday, that was way back. The cost of the more modern replacements is astronomical. It's no longer a matter of buying a few pieces of equipment to replace the joint, but it comes in sets, which are, yes, expensive, but apart from the expense, which sometimes could be addressed, we have the skills of the surgeons. Most of them can do these surgeries, but there's need for the specialized theater staff. The nurses, way back when I was there, the nurses were specialized in those areas. We are losing those now, or they have retired or what have you. So the drive will be on now to have staff trained to be able to do these replacements. We need an array of instruments, new instruments to satisfy these particular surgeries, new implants and the kits that come with them. So the major parts of that are the staffing issues and the specialists. We would need technicians and so on to address that. The other issues that came up earlier too also apply here in terms of, and we're working on that now. The minister alluded to that. He's working on it. We both are working on it, and we hesitate a little bit to give you the results until we have the full picture. But we have to work on with the new Chief Operations Officer and finding out the issues within the theatres. What's the reasons for the backlog? There are many. More than one is more than what you alluded to earlier, not you necessarily, Member of Parliament, but that the surgeons are going in favor of having public patients be seen as private patients. It goes beyond that from a simple, quote unquote, in terms of scheduling theatre time. It's as simple as that. Once we could get the surgeries started on time, it would mean that more surgeries can be put into the day. There's also an issue of using the theatres on a 24-hour basis, and as I said before, that applies to several areas in the hospital, not only the theatres, but the labs, the pharmacies, something as simple or quote-unquote as the laundry. A lot of areas need to be placed as 24-hour. We have a 24-hour teaching hospital, but that does not necessarily go with 24-hour function in terms of the non-medical staffing. So these are some of the issues that we have with respect to the joint replacements and orthopedic surgery. There is room for another orthopedic surgeon if we do get one, or if we choose to have one, but the issue again is theatre time, and where will that new surgeon come in? As the minister said, the substantive minister said earlier, we're working on repairing other theatres, specifically within the Lions Eye Care Centre. Right now, as it stands, it seems that each theatre, functioning theatre, is each department, each area of surgery is responsible for a particular theater. Moving it to a 20-hour service would mean that more than, for instance, orthopedics has a theater, cardiovascular may have a theater. Moving it to a 24-hour service would mean that we could bring in other staff to use the theaters more efficiently. So these are some of the issues, but we are drilling down as to some of the causes, and that's the only way we could find solutions. So that's where we are with respect to the orthopedic department right now. Thank you.
Okay, just to get a little bit more granular, I understand what you've said there with respect to theater space and logistics and whatnot, and that perhaps would explain if there was a long wait, maybe a year or 14 months to actually get the surgery. But I understand that the surgeries are not being done at all. And this is really a case of creating two Barbadoses, because if some of the same consultants, and this is not, I guess, piggybacking on the previous statement or the previous contention I heard that people are delaying operations in the QEH in order to facilitate the funneling of patients to the private enterprise. But if some of the same consultants for the QEH do perform those surgeries privately, and it is not a case of it being a long waiting list to get the surgery done at the QEH, but a case of the QEH not doing it at all, then that means a certain section of Barbados has no hope at all for a remedy or anything being addressed with respect to their joint replacement, because some people, if you give them from now to the rest of their life, can never come up with the amount of money to have a joint replacement surgery. And that does not mean that their pain is any less. It affects them, it affects their families, it affects their way of life in the same way that it does from someone, for someone who's in a position to pay. So I know that I hear you loud and clear, Minister and the substantive minister. Both of you I have the ultimate respect for. I know this is not an issue of your own making, or even the previous minister, if you say that the last joint replacement surgery was in 2012. But it is not something we can kick down the road, because the pain is very real for those who are living with it daily with no hope of having it corrected. So I would like some comfort that this is something we're looking at addressing, or that we will now look to address it, so that all of Barbados will be able to get the treatment for the ailments that they have, whether privately or whether under the government service. But they cannot be something that is available in the private sector that is simply not available in government if we have the same surgeons working across the borders.
The point I was trying to make, and I am probably more acutely aware of the joint replacements than you are. I have a parent that had two, in fact, and several patients that are actually waiting on the list. But the problem is, one of the problems, before we get to the cultural aspect of it, is that we have the skills of the doctors, but we do not have the equipment. We do not have the kits to do the joint replacements. Yes, they're costly, but once we could get the theater space available, bringing in the other consultant and so on, I am positive that we will move forward to some extent. I can't tell you in the next couple months, but that is the way ahead. We can't have people living in pain. I agree with you. I agree with you fully. But we have to drill down on the aspects of why surgeries are delayed, and that's what we're working on now. Then we have to address sourcing the items that we need for the surgery. Then we have to address training of the individuals to carry out the surgery, and training by, I mean, technical staff, specialized nursing. You can't just pick up a nurse from off a ward to do this kind of surgery, theater surgery, in fact. These are the resources. We have to get these resources down pat first. We have to get the funding for these, and then we will move forward. And I too, like you, I'm hoping and praying that we seek a resolution to this, and I'm confident that in the future that will come.
Thank you for your very thorough answer. So just for my final question, so in light of the fact that this service is not provided for at the QH, is this something that persons can get funding from the relevant fund to have done privately?
Thank you, Minister. Let me say that we will have to explore that. The medical aid scheme is currently capped at about $1.2 million, as I indicated. But we are going to have a understanding, as Minister Brown indicated, of what is happening there. What is needed, though, is that we must have an action plan to address the issues that you raised. Like I said in my introductory remarks, we are working on the process of discovery to understand a little bit more what's happening in there with respect to those who've been on waiting list for a prolonged period of time. So once we are in possession of the facts, we'll be able to come back to you separately or hopefully in another forum to advise you, Honourable Member.
Thank you very much. I take comfort in that.
Thank you, Honourable Minister and team. You have done well. You may now proceed with your wrap-up.
Thank you, thank you, Mr. Chairman and honourable members. I must say that once again, thank all honourable members for their contributions. We have taken very careful note of your suggestions, and in fact, we have received many at today's session. I would like to thank my colleague minister, who stayed in the well with me through the entire discourse, as well as the permanent secretary, chief medical officer, and all others who participated in today's session. I must remind you that healthcare will revert to the non-COVID practice where we have to get out there and we have to return to taking healthcare back to the forefront of what it used to be before we were faced with the COVID-19 pandemic. I will also commit that the Queen Elizabeth Hospital should start a series of outreach town hall meetings. It is necessary for us to continue to listen to the public and to hear from them so that we get a better feel and handling of the issues at hand. We are busy as a ministry and those other departments of the ministry working on all the challenges that we have to resolve in the shortest possible time. The issue of the backlog of surgical and non-surgical procedures remain a priority for my ministry, and we will do whatever is necessary in the shortest possible time to commence the process of the reduction in surgeries, in the waiting list for surgeries. Regular updates will be provided to the public, and I commit to the public that we will do so in a very timely and orderly fashion. This job is indeed going to be a very challenging one, like all the others that we've had collectively. But I'm confident that the team of professionals that we have and that I've had the opportunity, along with Dr. Brown, to interact with over the last 5 weeks, that this team is a very capable team. They have the right temperament, they understand the issues at hand, and they are very highly trained professionals. And with that, I'm sure that they will continue to cooperate with both ministers as we execute the mandate on behalf of the government of Barbados and certainly the people of Barbados. And in saying that, Mr. Chairman, I would like to move that Head 86 stand part.
Wait a second.
The question is that Head 86 stand part. All honourable members in favour, please say aye. Aye. Honourable members against, please say nay. Methinks the ayes have it. Honourable Leader of Government Business.
Thank you, Mr. Chairman. I beg to move that you do now report progress to His Honour the Speaker and beg leave to sit again.
The question is that I do now